Is now starting. All attendees are in listen-only mode.
One minute. Thank you so much. Hello, everyone, and welcome to this global virtual conference, the Epidemiology and Economics of Coronavirus. My name is Florencia Librizzi, and I'm the Head of Program and Partnerships at the SDG Academy SCSN, and I'm delighted to be your MC today. We would like to thank you all for joining us amid these trying times. Our virtual conference today focuses precisely on how COVID-19 global health pandemic is rapidly changing the way that we live and work, including how in the age of sustainable development, this disease is complicating how to achieve the SDGs, the Sustainable Development Goals, and posing really important ways to achieve that.
How do I do that?
How to achieve the targets on the health, education, life expectancies, and others. We're very excited and honored to have a distinguished group of leading experts to discuss the implications of COVID-19, as well as make science-based recommendations. So before we start, I will hand over to my colleague, Shannon Cobran, who will give us some brief technical guidance on the use of our webinar platform. Thank you.
Hello and welcome, everyone. Before we get started, I'd like to go over a few items so that you know how to participate in today's event. We've taken a screenshot here of the attendee interface. You should see something similar that looks like this on your computer desktop in the upper right-hand corner. If you're listening in using your computer's speaker system by default, or if you would, or you are listening in using your computer speaker system by default, but if you would prefer to join over the phone, go to the audio settings and select telephone in the audio pane, and you'll get dial-in information. You will have the opportunity during this webinar to submit text questions to today's presenters by typing your questions into the question pane of the control panel. You may send in your questions at any time during the presentation, and we will collect these and address as many as possible during the Q&A sessions at the end of each section of the presentation. Now I'm going to hand it back to Florencia to get us started.
Thank you, Shannon. Our agenda today is divided, please next. Our agenda today is divided in 4 sections, giving 10 to 15 minutes intervention from our speakers. We're going to have in each of the sections a question and answer opportunity for all of you to submit your questions, as Shannon was saying. So as you can see, part 1 focuses on the status of the epidemic, part 2 will focus on the control measures, part 3 on the economic impacts and as well as the economic management, and part 4 on the prospect of treatments and vaccines. Without further ado, I'd like to turn it over to Professor Jeffrey Sachs, President of SCSN and Director of the Center for Sustainable Development at Columbia University. Thank you, Jeff. I think you're muted.
Oh, here. Thank you very much. I was having a little difficulty unmuting. To our colleagues around the world, welcome today. Thank you for joining this workshop. We are at an extraordinary moment in the world, and we have to do everything possible to understand this crisis and to respond effectively to it. It is overwhelming our societies, overwhelming the global economy, and creating massive hardships. As of this morning, the number of confirmed cases around the world had climbed to 735,000. The number of deaths to 35,000. And of course, the number of confirmed cases is only a small shadow of the actual number of cases in the world. We probably have already at least 10 times, if not far more, cases. So 350,000, 735,000 confirmed could mean 7 million actual cases or even more, 1 per 1,000 in the population or even higher. But this is only the early stages still of what could be a horrific series of events unless we bring this under control. If you could move to the next slide, please. There are 4 aspects of the corona virus that make it especially dangerous. It is a new virus for humanity, at least for modern humanity. So apparently there is no or essentially no existing immunity. It is very easily transmitted by direct person-to-person contact. It is subclinically transmitted as far as we can understand, meaning that people who have no symptoms or very mild symptoms are transmitting the disease. That means that unlike SARS in 2003, it is transmitted by people who do not appear to be very sick. So it is hard to stop this transmission. And the 4th element is, while there is uncertainty about the infection fatality rate, it seems to be very high. This would be consistent with the fact that we are immunologically naive to this virus. For influenza, the infection fatality rate is estimated to be about 0.1 of 1%. The COVID-19 infection fatality rate is usually estimated to be much higher, 5 to 10 times higher, something perhaps as high as 1% infection fatality rate. Since we don't really know the total number of infections, we don't really know that number, but it is very, very large. In a mass epidemic like this with an immunologically naive population, this could spread, if uncontrolled, to more than half of the world's population. That would be more than 3 billion people. And if the case fatality rate is around 1%, that would be 30 million deaths. Horrific. What it means is that we must break the transmission of this virus before it spreads in an uncontrolled manner. Next, please. There is a policy sequence for those places, and there are now none essentially that have not been touched by the virus. The first stage is containment. A few countries, mainly in East Asia, have seemingly contained the virus at relatively low numbers. No country now at 0, as far as I know. 999 countries and territories with confirmed cases as of this morning. But containment means to stop the community spread of the virus at very, very low levels. Perhaps Hong Kong, Singapore, Japan, Taiwan have had relative success in this early stage, but it's too early to tell. The second stage in the sequence around the world was recommendations on social distancing, so-called, or better put, physical distancing. And that is the current response that was the initial limited response. We have moved quickly to a much more drastic reduction of contacts, a partial economic shutdown, which is now affecting more than half the world. Countries, one after another, are stopping non-essential economic activities. It's a drama. We've never had anything like this. Now, the next stage of the policy sequence has to be ending the epidemic itself and restoring economic life and daily life. Next, please. If you look at this graph of the confirmed cases in East Asia, they show that Japan, Taiwan, Singapore, and Korea, shown here, have all seemingly avoided the exponential phase of the epidemic. If you go to the next slide, China seems to be, if the data are accurate, a crucial case for us of a country that reached the epidemic stage, the exponential growth, reached nearly or around 80,000 confirmed cases, maybe many more unconfirmed cases, and then seemingly has leveled off if the data are accurate. This would be an enormously important case for us to understand in detail, because it is the one case where the exponential epidemic phase apparently has been brought under control. Next. In Europe and the United States, we are still in the exponential phase. My city and state, New York City and New York State, is definitely in the explosive exponential phase right now. We have not yet had the kind of success that China, we hope, is having in containing that explosive phase of the epidemic. Next, please. What are the major policy issues for us to discuss in the coming 4 hours? First, how to break the epidemic. That does not mean to flatten the curve to reduce the peak. It means to stop the transmission substantially so that we don't end up with billions of people becoming infected. We must stop the epidemic, not merely slow it. Second, we urgently need to bolster the hospital systems around the world, which are completely unequipped for the inevitable flood of patients who are coming in to the hospitals. Third, we must build the public health capacity. It's important to make the distinction between hospital care to save lives and public health systems to trace infections, test people, provide isolation and quarantining facilities. This cannot be done by the hundreds of thousands. It can only be done in the early containment phase or after the partial shutdown has brought the infection down to a much lower level. But we must build the testing, tracing capacity urgently so that we can break the transmission. Fourth, we must protect the vulnerable. There are two kinds of protections. Those with prior health conditions like diabetes or cardiovascular disease, high blood pressure, are highly vulnerable to death. And the older population, 60 and above, has the disproportionate share of mortality. They must be protected. But also the indigent, who will not have a livelihood for weeks or months ahead, must be helped urgently. The next area to mention is the financing of this response. This will cost a lot in the short term. We will have unprecedented pressures on public budgets, deficits of 10 or 20% of the gross domestic product in the short term, at least. And so this is a drama of financing. The next policy issue is how to follow a partial economic shutdown with a partial economic reopening that does not lead to a new explosion of the epidemic. This is the stage that China is attempting to accomplish now. It is seemingly making progress if the data are to be validated. Finally, is the challenge of finding therapeutics and a vaccine. And this is months or perhaps years away, but we must invest now. Next, please. So we now return to the program. This is to set the stage. Let me thank all of the participants, people viewing from around the world, and also especially all of the panelists. So we have a superb world-leading group of panelists. And Florencia, let me turn it back over to you.
Thank you so much, Jeff. We will now hear from Carlos Chacur, Assistant Research Professor at IS Global. Thank you, Carlos.
Thank you. So thank you for the invitation. I will present the European stage on behalf of Anthony Plasencia, who's the director of IS Global, who has a high-level meeting, but I'm happy to go through his slides. If we could go through the next, please. So this slide is to mention that the outbreak in Europe started quite early in the global process. If you look at this slide on the left, you have the report of the Wuhan pneumonia cluster that was reported in December 31st, and the first case in Europe was reported in France about 3 weeks later on January 24th, and that same week was followed closely by cases in Germany, Italy, Finland, Spain, Sweden, and the UK by the end of January. If we can go to the next, please. Now here, a second important concept is that until now, Europe has become the epicenter of the outbreak. If you look here in yellow, is the proportion of cases that were diagnosed in China until by week, and you see that China clearly dominates for the first few weeks of the pandemic. And then when Europe comes into the scene on the first week of March, it very quickly takes over, and for the last week, more than 50% of all cases in the world were diagnosed or reported in Europe. Note that this has been quickly being overturned by the situation in the Americas that is growing faster. We could go to the next, please. Yes, so this slide, as the situation changes so quickly, this slide shows the number of cases as last night, but it has an insert that if you click in the next, it will show that it's not just about number of cases being cumulatively reported. Could we go to the next, please? Yes, so there is an insert to show the growth factor, which is the proportion of growth in each number of cases reported daily when compared to the number of cases reported the day before. And what you can see here is that the growth factor seems to be levering down to around 1. And right now, as of today, is around 0.89. So there is an early indication that perhaps the number of new cases will start to be less than those on the previous days. A bit early, but this could be the first indicator. Could we go to the next, please? Yeah, so this is to reflect the burden in Europe. And I think as of today, these slides are from 2 days ago. As of today, the rough numbers are Italy has around 100,000 cases, Spain around 80,000, Germany 60, France 40,000, and the UK about 20%. So this gives you an idea of what the disease burden is today. And if you go to the next, we can look at a different indicator, which is incidence. And these maps reflect the cumulative incidence in the last 2 weeks. In B and in A is the previous 2 weeks. And you can see that there seem to be two groups of countries, Italy and Spain in the south, with a much higher incidence or cumulative incidence in the last 2 weeks. But Germany is tailoring very close and starting to report more cases given their higher testing rate. So we've presented burden and we've now presented incidence. Can we go to the next, please? So in this graph from the Financial Times, you can also see what we were trying to mention before. This is countries and cases. And you can see in the top, we have marked Spain, France, and Germany as a group with the highest burden, but seem to be followed closely by a second group with seemingly lower current burden. But if you look at the trajectories of these two groups of countries, they're following the same trajectory. So maybe the UK and Switzerland and the Netherlands and Belgium are having a relatively lower burden, but they continue to grow at the same rate. Can we go to the next, please? Yes, so this is the curve for the same countries now showing deaths. And this, again, from the Financial Times, I think is very useful because it marks when measures were taken, and it shows that the city of Wuhan and the province of Hubei in China locked down after just 30 deaths. And in Spain and France, this occurred after 200 deaths, and Italy did it after 800. But you can see again the same concept that the trajectory of the countries seem to be very similar in what it is cumulative deaths. If we go to the next one, please. And this slide shows cumulative deaths, but now at subnational level, showing that Lombardia is the highest subnational level affected in Europe. But in Spain, Madrid, and Catalonia very closely, also with the area of Paris. London seemed to be with a lower rate of death at subnational level, but if you look at the trajectory, it seems to be going up. Can we go to the next, please? And this is to show the hospitalization rate divided by age groups. And as you can see, in Europe, this is a figure from the ECDC. You can see that the highest proportion of hospitalizations is occurring at those over 70 years of age, 70 to 79, and those above 80 years. Above 60 years of age also start to raise and the number of hospitalization. And so this is clearly a disease where the severity burden is occurring in the elderly. Next, please. Here again, not hospitalization, but fatality rate of cases in Germany, Italy, and Spain. And you can see this reflects very well the hospitalization rate, with Italy and Spain having a much higher case fatality rate in those over 80 or those over 70. And in Germany, this phenomena is not occurring so far, and there's been a series of discussions on this about the social dynamics or the ICU capacity or the number of tests being done currently. Next, please. And here we see the correlation in several European countries marked yellow to show the number of tests done versus the number of cases reported. and there's a clear correlation between number of tests and cases reported, and this is shown better maybe in the next slide. That shows that countries that seem to be testing the most are in the lower part of the graphic. You can see Germany and Norway in Europe as the representation of the countries that have the most testing, and that leads to reporting of a large proportion of cases. Note there are wide confidence intervals, but in Germany, for example, you can expect that between 55 and 85% of all cases are being reported, while in countries on the top part of this graph, such as Spain and Italy, the number of tests is less, and this leads to a much lower number of cases reported. Next, please. Yeah, this slide is a bit busy. I'm not going to go into detail, but this shows different measures taken in different countries, and this includes a decree of state of emergency, a full lockdown at country level, border closures, closure of non-essential shops, close of universities and restaurants and leisure activities, and then restriction of public gatherings. And you can see that most countries took these measures either around February or early in March. There's some exceptions, with Italy going into a state of emergency late January, with Switzerland going into restricting public gatherings in February. And then those white boxes, you can see Germany, for example, has not started an emergency state. They have not undergone a lockdown. In the UK, there's an exception on border closures, I guess, because they have these natural borders. Switzerland also has not started a lockdown, and the Netherlands has non-essential shops open for business. So there are exceptions, but most countries in Europe seem to have taken very similar measures around very similar times. Next one. So the situation today is this in most countries in Europe, with a panorama that is only seen in some movies, with empty landscapes or empty urban landscapes. And we are still to see what's the progress of this in the next few months. Thank you.
Thank you so much, Carla, for that insightful presentation. Now moving on, we are going to turn it over to Alison Galvani, Director of the Center of Infectious Disease Modeling and Analysis at Yale University School of Public Health. Please go ahead, Dr. Galvani.
Oh, can you hear me now?
Yes.
Okay, great. So first, I'd like to thank the Sustainable Development Solutions Network for mobilizing so quickly to organize this conference on the global COVID-19 crisis. The outbreak in the US is growing steeply and spreading widely. With over 140,000 confirmed cases, we now have the horrifying distinction of a higher incidence than any other country. And I believe it didn't have to be this way. COVID-19 is exposing the systemic frailties in our pandemic preparedness and our social security net, and above all, in our healthcare coverage. These systemic frailties have exacerbated a series of missteps that combine to fuel the spread of COVID-19 throughout the US. In the hopes that we might learn from our mistakes, I'd like to dissect the factors that contributed to this crisis and to discuss some possible action points that could help to cauterize the devastation as far as is now possible. So the first misstep dates back to 2018, when the Trump administration dismantled the Global Health Security Unit dedicated to pandemic preparedness. Without that global expertise in place, we fumbled over pivotal opportunities to control the outbreak early on. As a consequence, we squandered the first 9 weeks following the reports of a novel, virulent, and transmissible respiratory virus. By January 21st, diagnostic protocols had been developed by multiple teams. Coincidentally, this was also the first date of the first confirmed case in the US. By February 5th, the CDC had ramped up production of test kits and sent them to local public health agencies. Unfortunately, these tests turned out to be faulty. This is particularly tragic because there were teams outside the CDC who were capable of producing tests, but federal approval that would have permitted the use of these tests for diagnostic purposes was held back. Suspected cases of COVID-19 were showing up at hospitals. However, the vast majority were unable to be tested. With scarce diagnostic capacity, we were hampered in early containment efforts, which rely on contact tracing and case isolation. As a result, we were walking blind into the eye of the storm. By February 26th, community transmission was occurring in the states of Washington and Oregon. Meanwhile, the US president was repeatedly minimizing the gravity of the crisis and overpromising the resources needed to combat the outbreak. As just one example, on February 28th, it's going to disappear. One day, it's like a miracle, it will disappear. Finally, on February 29th, the FDA approved clinical tests by facilities beyond the CDC. And on March 13th, large-scale companies started producing COVID-19 tests. These missteps are reflected in the number of tests that were administered in the US compared to other countries such as South Korea. Notably, South Korea had confirmed its first case the very same day as we did. Per capita comparisons of testing are even more stark. South Korea is an example of a country that hit the ground running in their implementation of widespread diagnosis, and they rapidly curbed COVID-19. More than 37 million people in America have no health insurance. Another 41 million have inadequate insurance, which means that their co-pays and deductibles are not affordable compared to their income. Indefensibly, there are cases of people suffering from COVID-19 who have been denied treatment because they do not have insurance. One such person was a 17-year-old boy in LA who was denied treatment at an urgent care clinic and died later that same day. This is a uniquely American problem. I do love my country, but I am ashamed by the routine denial of medical treatment here, and which I regard as a human right violation. Notably, Texas, as you can see here, has one of the worst levels of healthcare coverage and is governed by a man who recently argued that preserving the economy is more important than saving lives. Oops. Compounding the problem, the US is the only high-income country that does not guarantee paid sick leave. In addition to being inhumane, it puts our entire society at risk when some among us do not have the means to stay at home when they or their children are sick. In our modeling work, we have projected the need to expand ICU and ventilator capacity. Unfortunately, these projections are being borne out by what is now occurring across the US. The influx of critically ill patients is quickly overwhelming healthcare facilities. Some hospitals are even grappling with shortages of personal protective equipment, including masks and gloves. These shortages cost lives. I fear that many thousands of Americans will die before the outbreak is extinguished, and that the catastrophic scenes we are seeing out of New York will be replicated in every state across the country. Our modeling results also show the impact that self-isolation can have in terms of reducing and delaying the outbreak peak, both of which are fundamental to minimizing mortality from COVID-19 and buying more time for the manufacture of vital medical equipment. So where do we go from here? Evidence decision-making is imperative. Lifting measures prematurely will cause a rebound and will ultimately lead to greater human morbidity and mortality, as well as more pervasive economic repercussions compared with a concerted effort to maintain social distancing until COVID-19 is brought well under control. Scientific leadership, as has been exemplified by Tony Fauci, is indispensable. Accurate communication with the public will bolster the trust that is essential to promote public adherence to policy recommendations. Several state and local leaders have provided upfront communication to fill the gaps where the federal government is failing. In the absence of national coordination, states are literally competing against each other to purchase desperately needed protective equipment, driving up prices and delaying distribution. We need federal coordination of the production and distribution of PPE and ventilators. Pharmaceutical research development could be a game changer if efficacious vaccines and antivirals become available. Above all, I believe that universal health care is paramount to the continued prosperity of our country in the face of this pandemic and in addressing other infectious diseases. Further, universal health care will be most cost effectively achieved by a single payer system, such as that proposed in the Medicare for All Act. Finally, I'd like to thank the organizers of this conference, my colleagues for their dedication, and most of all to the frontline workers who are risking their own lives to save the lives of others day in and day out. Thank you.
Thank you so much, Dr. Galvani, for this presentation. We're now moving on to the next speaker, and I would like to turn it over to Nicia Trindade Lima, President of Fiocruz, to hear her presentation about the Brazil situation. Thank you.
Good morning. First of all, I'd like to thanks for the invitation. Thanks for Sustained Development Solutions Network. Thank you very much. It's an opportunity to think and share some information about the Brazilian situation. We are in the beginning of the pandemic, and it's very important to think about solutions, measures, and share all these ideas so important in this moment. The COVID pandemic must be understood as a global disaster, producing a humanitarian crisis in many countries. Disasters by nature and definition are events that result in a serious interruption of the normal functioning of a community or society, affecting their daily life. Simultaneously, material and economic losses, as well as environmental and health damage to populations through injuries and diseases that can result in immediate and subsequent death. COVID-19 confrontation of the pandemic, although it requires immediate and medium-term measures, cannot be dissociated from a perspective that also combines the long-term and strengthening of policies, measures, and actions oriented towards sustainable development and expressing the sustainable Development Goals. Some characteristics of this pandemic are important to think about its confrontation in Brazil. This being, first, it is not a national problem, but a global one that affects almost all countries. Second, its potentials on health and social will not be restricted only to short-term ones, because its impacts tend to extend beyond the months of the pandemic. Third, involves the combination of complex problems with a high degree of local and regional variability. Fourth, requires decisions under conditions of urgency in a context in which there are several scientific uncertainties about the evolution of the pandemic and the measures in very heterogeneous social, political, and economic contexts. Maybe the last is one of the most challenges in countries as Brazil. In addition to these characteristics, we must consider that the Brazil entered the crisis already in a fragile situation, without fiscal capacity, enormous uncertainty, and serious institutional instability. The combination of these characteristics makes the pandemic a potential disaster in Brazil, which combine with the existing conditions of social vulnerability and the limits of Brazilian public health system, SUS, to respond quickly, can result in a humanitarian crisis. I hope we can deal in the best way with this kind of challenges. Please, the next slide, please. This slide shows the rapid evolution of cases and deaths in the last week. We have now confirmed cases 4,256, 136 deaths, mortality rate of 3.2%. It is estimated that reported cases in Brazil represent approximately only 11% of the total. At the beginning of the week, the next, please. There were 1,891 cases and 25 deaths. On Friday, March 27, there were 3,417 cases and 92 deaths. The number of cases increased one time in deaths in less than a week. You can see the new cases for day in this figure. Risk and alerts. The urban centers of the southeast and south regions have a high probability of accumulating severe cases in the short term, with a high percentage of population over 60 and over 80 years of age, and having a higher history of severe acute respiratory syndrome. By Friday, São Paulo and Rio de Janeiro had half of the cases. São Paulo, with 36% cases, being the epicenter of the epidemic in the country, and Rio de Janeiro with 14%. Besides that, 25 of 27 federations units read records of cases, with growth trends in all. It is estimated that 8% of the Brazilian population depends entirely on the Brazilian public health system for health care. And it's important now to show the problem of the beds per inhabitants, especially ICU problem. So we can see in the slide 30, the ICU beds in the SUS, Brazilian Health System, per 100,000 users. In the system, 316 of 436 health regions concentrate 56% of the population, are already below the desirable minimum of 10 beds per 100,000 inhabitants. Of these 316 health regions, 142 health regions do not have any beds, as you can see the dark color in the slide, represented 14.9% of the population that depends exclusively on the SUS, public health system. From the installation of sustained transmission and high incidence in Rio de Janeiro and São Paulo, export of cases to the rest of the country should follow the pattern of internal mobility, plus the importance of cases from abroad. The most likely micro-regions for the installation of sustained transmission of COVID-19 are the micro-regions that border the cities of São Paulo and Rio de Janeiro. The next, please, is the first map. The second map shows the probability of an outbreak in a secondary round of propagation after the establishment of transmission in the microregions of great risk. These maps are product of one of the most important epidemiological research group at Fiocruz, and they are just study the tendencies of the spread, and these research results are very important to embase the strategies, especially isolation strategies in the country, necessary in this time. The next one, please. On the slide, we see maps according to vulnerability indicators. On map A, on the left, we can see that the urban centers of the South and Southeast regions have a high percentage of the population of 60 years old, which constitute the main population at risk, and a low effective distance from São Paulo and Rio de Janeiro, the epicenter of the pandemic in Brazil. Map B shows a slight trend towards a great number of complementary beds, ICU, and the intermediate unity in microregions close to São Paulo, Rio de Janeiro, which suggests better coverage in large urban centers in the southeast and south. On the map C, we identify 5 classes of social vulnerability in Brazilian microregions, ranked from A, less vulnerable, to D, E, most vulnerable. This classification took into account the following variables: life expectancy at birth, Gini index, high GI education component, percentage of population living in extreme poverty, percentage of population living in urban areas, percentage of people in households with water supply and inadequate sanitation, percentage of households with running water, percentage of households without electricity. These data are important to show not only the situation in Brazil in terms of the continental country that we are, but at the same time, the inequality among Brazilian regions. And map D shows the microregions with a high probability of epidemic in the short term, and which also have high social vulnerability, the yellow color. They are concentrated in the Northeast. These are regions with a large influx of travelers and high social vulnerability. So the microregions with greater vulnerability, because they concentrate the highest proportions of poor and extremely poor populations, are the regions north and northeast. In office, we are in the beginning of the pandemic, and some states show now very important data to be followed. Although the evolution of the pandemic in Brazil presents characteristics of our social and economic reality, large inequalities, and environmental degradation and poor sanitation in large urban centers. Although necessary, measures of social distancing and the restriction of mobility that I think are very important in this time, as I have mentioned before, have limitations to various forms of social vulnerability. And I think that's very important to stress this topic. So about socioeconomic vulnerability, about 16 million people live in Brazil in households with per capita income below half a minimum wage. 26 million are employed in the labor market as self-employed, 19.3 million of them informal. In this context, measures of social distance and the restriction of mobility are necessary but have to be combined with economic and social measures as income transference. Vulnerability in the labor market and health is another important point. Approximately 50% of patients with chronic diseases participate in labor market in Brazil in 2013, while 4% of the population aged 18 years or more were simultaneously with chronic diseases and self-employed, very young people with this kind of problems. A very large proportion of Brazilian workers are particularly vulnerable to COVID-19 because of age profile or chronic diseases. As an aggravating factor, many are self-employed, typically economically vulnerable. In this context, how can we design policies and distribute resources in order to better protect the most vulnerable in the face of COVID-19 risk in times of mobility and social interaction restrictions? That is an important challenge. At the same time, you have to face an economic crisis. Urgent aid measures focusing on the poorest and the most vulnerable are needed. In addition, combined with mechanisms that include families not yet registered with the utmost urgency, but who will quickly need assistance. Last week, the Brazilian Congress approved a measure for income transference for informal sector in the poorest part of the population. But now we have to see the quick implementation of this kind of policies. That is an actual challenge. In addition to the problem of hospitals, beds, and ICUs, we have to mention the primary care network in Brazil, with 74.8% of the population covered by primary care and 64.5% covered by the family health strategy. That is an important resource of the Brazilian health system for coping with the pandemic by COVID-19. Finally, the main challenges we have identified in general are to understand the pandemic as a natural disaster with a high impact in health, with social and economic disruption, and that it's a global event with a combination of problem complexity, local and regional characteristics, short and long-term health, social and economic effects, and decisions made under pressures based on partial information. And the main challenges for Brazil are that we can see at this slide, I'm not going to read every topics, but I would like to stress that the urban peripheries and north and northeast states concentrate social and economically vulnerable populations, and that social distance and case self-quarantine are difficult for the vulnerable populations that already face challenges in access to water and sanitation, adequate housing, and urban planning. In summary,
yeah, for this, and we'll ask you to wrap up quickly so we can move on to the questions and answers. We have actually quite a few questions from our audience.
In summary, the pandemic in Brazil requires public health and social protection measures in order to avoid a potential disaster, which consequences and negative impact are known. But I think we can avoid many of them with the right measures and a collective project just in this time. Thank you very much.
Thank you very much, Nicia. Now we're moving on to questions and answers, and we have seen quite an active panel here in the chat. So we thank you so much, everyone that is listening to us. And we can see a trend on the questions asking mostly what is the result of the impact of the COVID-19 related to the SDGs. So I will read a couple in that sense, and perhaps one of the speakers, maybe Jeff, you can take this on. This one, for instance, it says, how do you see this COVID-19 experience, knowledge, and application affecting the impact of SDG reporting?
Well, we're in a very early stage of this. So right now, all attention is on the emergency in fighting the epidemic. We're going to have to consider the implications for the longer term shortly, but frankly, right now, this has overwhelmed all processes, I would say. So all normal processes at the UN, all normal SDG processes really are in a way suspended right now to get through this absolute emergency. More than that, we'll have discussion in later sessions and panels about the economic impact and also addressing the kind of extreme social conditions that we just heard about. So we'll be talking more about this as the morning continues.
Thank you, Jeff. And maybe very related to this, this question says, did SDG implementation plans envisage and prepare for such large-scale shocks, such as COVID-19? Basically, there was any contingent plan here?
Well, just to add, the SDGs were chronically underfinanced, underperforming, and underattended to even before COVID-19. It's a struggle. I won't say there is a silver lining to a global disaster. There isn't one, but it will put attention on the critical dimensions of life, death, extreme poverty, and vulnerability, which are the very essence of the Sustainable Development Goals. It will surely force us to attend to these life and death issues.
Thank you very much. And this is another question, perhaps any of the speakers that would like to take it. This is related to the WHO. It says, as a result of COVID-19, will the WHO role become more vital in pursuing sustainable development in the future? Any of the speakers, or perhaps Jeff as well?
I'm sorry, could you repeat, Florencia? I think we've all missed it.
Yes, absolutely. So basically, this question asks about the role of the WHO related, whether the COVID-19 will perhaps make more visible and more vital the role of the WHO.
Well, just to say, as one who has been engaged with the WHO directly for 20 years, the role always is vital, but chronically underappreciated, except at moments of crisis. The WHO is absolutely essential for many aspects of this epidemic, especially global notifications, advising, measurement, data, intergovernmental cooperation. And so the role must be enhanced. And there are many ways we'll talk about, for example, with the IMF providing urgent financing, that the cooperation between the IMF, the WHO, and the member states of the UN is paramount right now.
Thank you so much, Jeff. I see that there are a few questions on migration, and since we're touching on this in the next part that we're just about to move into, we're going to post those for the speakers that are coming, since that makes sense. Maybe just one more question, and then we move to the second section. So this one is on comparative data. It says, I would like to see comparative data of positive cases between countries considering the same amount of people that they are being tested. Some countries that might have many positive cases might be because people are being tested. Do you have a source that analyzes that? And just to say, we can also continue to answer this type of questions via email, but is there any insight on this question from any of the speakers? I think perhaps, yeah, we can follow up with this one. This seems that based on what we hear from the speakers, there is a trend showing exactly that, right? As people being more tested, more positive cases appear. And then therefore mortality also rate seems to go down, right? It's early to tell, but I think we can certainly circulate some links. And maybe just to say the trends team from SDSN has been doing wonderful work in compiling resources. We have some links to share with you in the Learn More final section of this conference. So I think we're good to move to the next session, right? So part 2, which we will focus on the detailed protocols of control measures. So our next speaker is Professor Byung-Yul Jun, Dean of CHA University School of Medicine from South Korea. Professor Jun, the floor is yours. Thank you so much.
Hello?
Hello, Professor Jun, we can hear you.
Oh, yeah, thank you so much. How about the picture? You can see my picture.
Slide, PowerPoint slide.
Oh, good. That's good. Yeah. Good morning, everyone. I'm Dr. Byung-Yul Jun, former director of KCDC, and now professor at the Medical School of Cha University. It's a great honor to join such an exceptional team of panelists prepared by KCDC. Next slide, please. Yeah, good. Here, you are seeing the COVID-19's timeline in Korea. There is a total of 4 alert levels in Korea, from 1 beginning the lowest to 4 being the highest. After seeing a cluster of cases of pneumonia in December 2019 in China, the Korean government immediately raised the alert level to level 1 on January 3rd, 2020. And the first confirmed case in Korea was detected on January 20th, and the alert level was readjusted to level 2. 5 days after Wuhan decided to lock down the region, the government elevated to level 3 on January 28th. From January 20th, when the first case was detected, to February 18th, there were 31 patients in total, which mainly consisted of inbound travelers from overseas and their contacts. The first main community transmission took place on February 18th after a mass gathering of a religious sect, Shincheonji. The number soared within a short period of time, with 91% of total confirmed cases found in Daegu, the region where the sect met. Due to this incident, the alert level was raised to the highest level of 4 on the 24th of February. Soon after, on March 1st, the government established a quarantine facilities for mild cases and placed focus on the treatment of severe cases. The government further divided and classified patients into 4 severity categories: mild, moderate, severe, and critical, to respond quickly to a sudden surge. Mild cases account for 80% of confirmed cases. Others are admitted to hospitals and are provided treatment. Next slide, please. From January 20th to February 18th, most cases were found among inbound travelers, and the curve was pretty much flat. And on February 18th, while doing epidemiological investigation of case 31, authorities found that the patient was a part of a religious sect in Daegu. The government followed up with intensive testing for all members of a religious sect, and the number started to surge during following days, reaching the peak on 29th of February. Since then, we've been seeing a decline in new confirmed cases. After March 20th, the number of daily new cases is around 100. As of 27th of March, the total patient number is 9,332. Next slide, please. Here, you can see the age and fatality distribution. First, distribution among ages. Ages 0 to 9 account for 1.2% of confirmed cases, which is 108 patients in total. Ages 10 to 19 takes up 5.3% of total cases. Those in their 20s account for 27.1% of all cases. Those in their 30s, 10.3%. People in their 40s, 13.5%. Those in their 50s, 18.8%. Those in their 60s, 12.5%. Those in their 70s, 6.8%. Those over 80 and above, 4.6%. Now, let's take a look at fatal cases on the right. As of March 27th, the total deaths from the virus amounted to 139. Case fatality rate as of 27th of March was 1.49%. There has been 0 fatality from those ages under 30. 1 death each from those in their 30s and 40s. 10 from those in their 50s. 21 deaths from those in their 60s, 41 from those in their 70s. For those aged above 80, 65 deaths. Just like we've seen from international data, the highest fatality rate was seen from those aged above 80, with 15.2%. The second highest rate was found among those in their 70s with 6.5%. Next slide, please. Now, these two graphs shows regional and cluster distribution. Please take a look at the graph on the left. Daegu has the largest number of cases with 6,516 due to the gathering of a religious sect, Shincheonji. A region close to Daegu, Gyeongbuk, has the second largest number of cases with 1,283, and metropolitan areas including Seoul and Gyeonggi have the third highest concentration. At the international airport in Incheon, 144 cases were detected once inbound travelers were screened. Let's turn to distribution by cluster. The religious let's turn to distribution by cluster. The religious sect Shincheonji, that is responsible for the first major community transmission, takes up 54.4% of entire cases. Following that is the category other clusters, which include nursing home, nursing care hospitals, customer call centers, and more. This category accounted for 27.4% with 2,556 cases. All of such facilities and places in this category are characterized by tight and enclosed space, as well as long working hours. 14.9% is either under epidemiological investigation or a sporadic case. Imported cases took up 3.3% with 309 cases. Next slide, please. This slide outlines the government-phased response to the virus. As mentioned earlier, the first case linked to Shincheonji was found on February 18th. On February 20th, KCDC started testing for 9,334 members of Shincheonji Daegu group. On February 23rd, the alert level was escalated to the highest level, and KCDC designated Daegu as the special management region and postponed the beginning of schools to March 9th. On February 25th, KCDC designated 91 hospitals in the country as COVID-19 protection hospitals. On February 29th, Korea saw a peak in terms of new cases, and government started the social distancing campaign. On March 4th, the school started date was postponed again by 2 weeks to 21st of March. On March 6th, government added more COVID-19 protection hospital and designated a total of 290 hospitals. On 18th of March, the school start date was postponed for the third time to April 6th. Next slide, please. Yeah. Now we are talking about laboratory testing. Before the Sincheonji case, tests were focused on imported case and contact. After the community infection in Daegu, KCDC has been running large-scale testing to identify and detect all cases. Ever since February 27th, 10,000 testing is being conducted daily nationwide. 118 institutions run COVID testing. Such institutions including KCDC, 4 national quarantine stations, 18 public health and environment centers, 95 private medical laboratories and hospitals. Next slide, please. Here, you can see photos of a drive-through testing site. Such sites have been constructed to ensure early patient detection. Next slide, please.
Dr. Jun, thank you. We'll ask you to please wrap up.
Yes, thank you. Yeah, this slide, contact tracing strategy, stepwise approach. And next, this slide, smart quarantine information system that was established after the MERS outbreak in 2015. Next slide, please. Here, you can see a self-health checkup app for foreigners. Next slide, please. Last but not least, this is Korea's social distancing campaign. Korea's campaign focuses on voluntary participation of the people. Main message revolve around how people need to keep 2-meter distance from each other and avoid physical contact, night out, religious gathering, as well as indoor fitness facilities. I'd like to end my presentation. Thank you all for your attention.
Thank you so much, Dr. Jun. Now we're going to move to the next speaker, which is Giovanni Ressa, Director of the Department of Infectious Disease at the Italian Public Health Institute, Istituto Superiore di Sanità. Thank you, Giovanni. Please go ahead.
Okay, thanks for your kind invitation. May I have the first slide, please? Next slide. Oh, okay. In what happened in Italy, everybody maybe knows that actually we detected the first case of the index case, the first case of local transmission on February 21. At that time, nobody, was thinking that the virus was already circulating in our country. The virus was detected, the virus circulation was detected in the north of the country, in the region Lombardia. Then on February 23, strict social distancing measures were taken in Lodi, that was the area that was firstly hidden by the infection, and a red zone, a so-called red zone, was implemented, and nobody could enter or go away from the red zone. A few days later, all the region Lombardia and the region Veneto, that is contiguous to Lombardia, were considered the red zone. And then on March 4, there was the first national level strict social distancing measure that included school closure. On March 11, there was a completely national lockdown decided by the government because the situation was quite bad, especially in the north of the country. And you may know that the north of the country is very well organized, and Lombardia is one of the best health systems in the world. So we were very worried about the spread of the virus to the center, but especially to the south of the country that are considered less wealthy and less well organized than the north of the country. May I have the next slide, please? What is happening now? Next slide. It is happening that actually the number of cases reported up to a couple of days ago is about 74,000, and actually these cases, I mean, the number of cases is still increasing in terms of reporting of cases, but when you consider the number of cases by symptoms onset, actually you may see a stabilization or even a decrease in the number of new cases. So we are confident on the fact that these social distancing measures are getting some results. Next slide. Okay, this is a summary of what I said before. There's some problem in the slide. May I have the next slide, please? There are two maps. Oh, okay. As you may see, most of the cases have been reported in the regions of the north of Italy, in particular in Lombardia, but also in Veneto, in Piemonte, and in Piacenza. So it means that the infection is spreading by contiguity from the initially affected areas to contiguous areas, but also there's some spread at distance because another region in the center of Italy, in particular the Marche, is now heavily affected. Fortunately, in the south of the country, the situation is much better. Of course, there are some hotspots of high incidence of infections throughout the country, but the situation on average is quite good in the south of the country because the number of cases is relatively low, and we are confident on the fact that the social distancing measures taken at the national level have reduced the risk of spread of the infection in the regions of the south and in the islands. Next slide. One of the problems we have is the high case fatality rate that may explain by two different factors. One is the testing policy, because we are testing mostly people with symptoms and especially people entering hospitals. So we are mostly testing people with more severe symptoms. For this reason, the case fatality rate is quite high. The other problem is that Italy has a very old population. So you may see that case fatality rates increase after in people that are more than 70 years old, and are especially high among people who are 80, 90 years old. So the problem of a very old population is becoming a very acute problem in our country with this epidemic. Next slide. One of the major problems has been hospital outbreaks. We had actually many hospital outbreaks, especially at the beginning of the epidemic, and this is why maybe we didn't expect actually to have such a high amount of patients with infection, and also because probably healthcare workers were not prepared to deal with this problem, and they were not used to utilize protective equipment. So that was one of the major problems, and probably several hospitals were amplifiers of the epidemic. And this occurred also in the north of the country, where actually we have a good hospital system, but in terms of individual protection, it was not as good as we expected. Next slide. Oh, this is the map of Lombardy, and you can see the red zone. That was the area where the epidemic started. And you may see, in terms of new cases reported, and also you may see the epidemic curve about symptom onset, that actually we now are observing in the initial red zone a decrease in the epidemic curve. You may see we are assisting at a decrease in the number of new cases of COVID. And next slide, please. We are using mathematical models in order to estimate actually the R0, the reproductive number of the epidemic. And you may see that the epidemic number reached 3 1 month ago, where we were in the center actually of in the middle of the epidemic. But then after the measures were implemented, we observed a rapid decrease in R0. This is at the national level. You may see the R0 was quite high at the beginning of the epidemic, was almost 2.5, between 2.5 and 3 at the beginning of the epidemic. Then there was a decrease, then it increased again between 3 and 4, was quite high when the regions of the north were heavily affected, but also there were some outbreaks in the center and in the south of the country. Then we implemented the measures, the social distancing measures at the national level, and now the R0 is estimated to be a bit lower than 1. I mean, a bit lower than 1. If the R0 is just a bit lower than 1, you may assist a continued trend in new cases of infections, but anyway, the number of cases will decrease very soon, we hope. And you may see the trend in the R0 in different regions, in the most heavily affected regions of the north. This is Lombardy, this is Emilia-Romagna, this is Veneto. And as you may see, actually the R0 is considered now, is estimated now to be lower than 1 in Lombardy and Emilia-Romagna, and to be around about 1 in Veneto. That means that social distancing measures are working, but we still need to decrease this R0 in order to have a more effective, a better effect of social distancing measures. So the last slide, just to conclude, actually, the faster you intervene, the better it is. I mean, you have to intervene very fast, because otherwise it's very difficult to control and to contain this epidemic. There's a focus on fragile settings. I mean, we had to protect especially older people, because they have very high case fatality rates. And then there are some issues about home quarantine, because we actually are isolating patients within the houses. And so there's some, even though social distancing measures are working quite well, I mean, there's still some in-house transmission, let's say familiar transmission, that is going on, because we are not using, hotels or other structures to quarantine. people to quarantine patients, and that's still a problem. And then we had to train healthcare workers because actually we had too many hospital outbreaks, and this was really an amplifier factor for the epidemic. So for this reason, I think that we need now, to continue with social distancing measures at the national level for a while. But meanwhile, we have a window of opportunity to train healthcare workers better and to study new measures in order to contain the epidemic. Thanks.
Thank you so much, Professor Ressa. Now we will move on to listen from Carlos Chacur, Assistant Research Professor at CIS Global. Thank you, Carlos.
Thank you. So I'll try to give a brief panorama of what's the situation in Spain and what measures have been taken. So we could start with the first one, please. Yeah, let's go to the next, please. Yeah, so I think there are at least 3 facts that we need to discuss before we can understand the situation. One is the country particularity, and that's related to the political system. Spain is a quasi-federal system, heavily decentralized, with health and education and other competences transmitted to 17 regional governments in what is called autonomous communities, and this has partly shaped the response to the epidemic. If we could go to the next one, please. Yeah, second point is that Spain has a universal healthcare system, and about 9% of the GDP is invested in this. The health system has been ranked as one of the best healthcare systems in the world. So this is also important to understand the situation. Next, please. Yes. Another important point to understand the current situation is the number of ICU beds, because previous speakers have shown that this is a disease which overwhelms the health system and particularly causes hospitalization in critical care units, mostly from the elderly. So Spain has about 10 ICU beds per 100,000 population, and in this graph you can compare with other European countries, probably led by Germany with around 30 ICU beds per 100,000. So this could also be contributed to the current situation. Next one, please. This is a very important point. The population pyramid in Spain has an arrow shape. So we have around 12 million people out of 46, which is the population. We have 12 million above 60 years of age, and 3 million people of those are above 80 years of age. The mean age of the country is around 43 years. Next, please. Yes, and this is a very important point. Spain is still recovering from the 2008 crisis, and this led to several social changes, including the presence of multi-generational households. And Spain today has 10% of households are 3-generational, which also contributes to the current epidemic. Next, please. Yes, I don't want to reiterate much on numbers, just to say that Spain has had a trend similar to Italy, but with absolute numbers going higher to the corresponding time in the epidemic. That means Spain has much more numbers today as Italy had at this stage. So Spain is probably going to surpass Italy on total number of cases, and of course also correcting by population size. Next, please. Yes, so at subnational level, the epicenter of the epidemic, just like it was the Daegu in Korea, in Spain has been Madrid, followed closely by Catalonia, the area of Barcelona, and both are following similar trends in number of deaths as Lombardia, and both are on track to surpass northern Italy in total number of deaths. As of today, we have around 7.3 thousand deaths cumulative since the beginning of the epidemic in Spain, 85,000 cases, 5,000 people in the ICU, and also on the positive side, 17,000 people recovered. Next one, please. This is the similar trend, but in number of cases, showing that Spain is following Italy very closely, and we just surpassed Wuhan or China and the number of cases yesterday. Next, please. So this I already mentioned, and the numbers have changed since yesterday, but we are above 80,000 cases, about 5,000 people in the ICU, and above 7,000 people dead. Next one, please. So this is to reflect the measures taken. The graph is from Worldometer, and as we scroll forward, the measures taken will be shown. So we will go to the next one, please. The first thing what happened is that Iberia, the national carrier, suspended. Can we go back, please? Yes. So Iberia suspended direct flights to Beijing. That's the first thing that happened, even before there were any cases reported. Next. Yes, so when there was already 3 cases at national level, the Barcelona World Mobile Congress, which is a major event that occurs yearly in Barcelona and brings thousands of people from around the world, was suspended at high economic cost for the city. That happened on February 24th. Next.
Pronto?
Yeah, so when we were already in March 9th, already reaching 1,200 cases, schools closed at national level, and there was an encouraging to work from home and avoid unnecessary travel. Next, please. Yeah. So by that week, a series of measures were taken. The first thing was not public sports events, so all football matches were played with closed doors. The major feast of Valencia was also suspended at enormous economic cost. Next. Yes, and as you can see, a series of stepwise approach was taken, trying to avoid a full lockdown. So right after closing school, there was a better on having indoor events for more than 1,000 people. Flights to Italy or from Italy were suspended that same week. Next. Can we go next, please?
Salve,
Yeah.
salve, Miguel.
On the 13th, right before going into
1, 2,
national
3,
lockdown,
4,
the
1, 2, 3,
parliament
4, 1,
suspended
2, 3, 4.
and no cruise ships
Sì,
were
sì,
allowed.
sì.
And next, if we go to to the next, which is the March 14, you will see that the state of emergency was declared and the country entered a lockdown that allowed work mobility. And that has been the measure until today. And if you go to the next, it will show in which the lockdown has been expanded further to actually prohibit work mobility. And this is police enforced. Next, please. Yeah, so right now, only essential labor is allowed. There's been an emergency draft for a law for this, and there's a police enforced traffic ban. Next. The economic measures taken include a relief fund that it's about 20% of the national GDP, a mortgage moratorium, and significant reductions of the social security costs for small and large businesses that sustain employment. Next, please. And right now, after entering a complete lockdown that even forbids work mobility, the country is moving to planned lockdown exit strategies in the very short run, because the first law that passed shows a lockdown until April the 9th. So we have 10 days to implement more sustainable solutions. I think probably the lessons learned is that a stepwise approach might not suffice to quickly reduce the epidemic spread once the growth is gone exponential. Thank you.
Thank you so much, Carlos. With all of these speakers, thank you so much, all of you. We have, I think, a great overview on the different situations in many places around the world, as well as the measures that have been taken. And now we're moving on a particular situation which comes with refugees and migrants. So we would like to welcome now our speakers, Oshi Karadak Kaman, research scholar from the Center of Sustainable Development, Columbia University, and also Yanis Ben Amor, Executive Director of the Center of Sustainable Development at Columbia University. Thank you so much.
Thank you so much, Florencia. And I want to thank the SDSN for giving us an opportunity to speak. So my name is Yanis Ben Amor. I'm the Executive Director for the Center for Sustainable Development, and my colleague, Dr. Özge Karadak Kaman, and I today will discuss how COVID-19 is going to affect migrants and refugees and our proposed response. Next slide, please. So I would like to first reposition our problem within the context of the Sustainable Development Goals. For those of you who are not familiar, there is no Sustainable Development Goals relative to migrants and refugees. So we are going to shape it with SDG 3, good health, and SDG 10, reduced inequality. Next slide, please. So for those of you who are not familiar with the SDGs yet, SDG 3 is about ensuring healthy lives and promoting well-being for all at all ages. And SDG 10 promotes reduction of inequality within and among countries. And I want to remind everyone that most inequalities are human-made. Next, please. So we have noticed an unfortunate increase in global numbers of international migrants, and it continues to outpace the growth of the world's population. The number of international migrants globally reached an estimated 272 million in 2019, which is an increase of 51 million since 2010. Currently, international migrants comprise 3.5% of the global population, which compares to 2.8% in the year 2000. Next, please. So forced displacements across international borders continue to rise, whether it is due to the war in Syria, the instability in Venezuela, or African migrants trying to reach a better life in Europe. There has been an increase for the last 10 years. So between 2010 and 2017, the global number of refugees and asylum seekers increased by about 13 million. Next, please. So the virus itself does not discriminate, but social determinants of health do. And here are some of the examples of social media messages from humanitarian organizations that we found that were trying to raise awareness on the situation in refugee camps. So you cannot hashtag stay home if you have none. You cannot hashtag wash hands if there is only one water tap for 100,000 people and no soap. And you cannot hashtag avoid crowds if you live in a refugee camp. Next, please. So migrants and refugees are disproportionately affected by the COVID-19 pandemic. Some countries report that the number of fatal cases of COVID-19 is unproportionately higher in some migrant group. And there are problems in primary, secondary, and tertiary prevention. And my colleague Özge is now going to walk us through those.
Thank you, Jens. So as you all know, international migrants are a heterogeneous group with both labor migrants and forced migrants, but in this presentation, we mostly would like to focus on forced migrants. And when we look at the problems in primary prevention, we see that poverty is one of the biggest problems because many of the migrants need to continue working under risky conditions for the infection. There are also problems with accessing healthy food, and we know that many of the forced migrants have nutritional deficiencies. There are problems with shelter and living environments, such as cold weather, overcrowded tents, or houses with 4 families living in the same household. And we also know that especially in camps, there are long queues for food, water, shower, which create problems with social distancing. So now we know that authorities are banning even 3 people to play basketball in outdoor spaces, but they also expect tens of thousands of refugees to implement social distancing measures in overcrowded camps. We know that there are problems in accessing water, soap, and sanitation, and also stress-provoking factors are also very important because for migrants, again, the level of uncertainty is higher and there's increased stigma and discrimination, increased hate speech, and increased violence. Because many people tend to blame that migrants, many people tend to blame migrants for this outbreak. Next slide, please. Can we have the next slide? So we also know that there are problems in access to reliable COVID-19 information and problems in access to information about available services. There's lack of personal protective equipment. And we also know that many of the outreach and work of NGOs and other institutions, as well as many asylum interviews and services for migrants have paused during this outbreak. We also hear that some countries deport migrants who test positive to their countries of origin. So in summary, physical, mental, and social problems affecting they all affect the immune system and increase vulnerability of migrants for the infection. Next slide, please. When we look at the problems in secondary and tertiary prevention, we know that there are difficulties in accessing COVID-19 testing. There's lack of proper quarantine and isolation opportunities. There are problems in access to treatment, and there's absence of surveillance and lack of data about migrants, especially for undocumented migrants. Next slide, please. So, no one should be left behind. We know that social determinants of health are strongly linked to how the COVID-19 pandemic evolves. And vulnerable disadvantaged groups with respect to social determinants of health, including migrants and refugees, should be on the agenda of policymakers and service providers for a comprehensive and effective COVID-19 response. Next slide, please. We know that health and well-being of migrants and refugees are not only important for migrants and refugees themselves, but also important for health and well-being of host societies, human and financial resources of host societies, and also for controlling the pandemic at the global level. So we need to remember that, especially during outbreaks of communicable diseases, None of the people will be protected if we do not include everyone. This means we're all in the same boat. Next slide, please. When we review key interventions to control this pandemic at the global level, depending on the size and characteristics of the camps and immigration detention reception centers, we should be thinking about either evacuating the centers or camps or reorganizing them. Quarantine and isolation places need to be prepared, especially in the camps or centers, and reorganization should also include protection of more vulnerable migrants, such as elderly and migrants with chronic diseases. We should also be distributing hygiene and sanitation kits. We should train the staff working at the camps and centers. We should be suspending all public activities, restricting number of visitors, and we should check new arrivals for fever and other screening symptoms. Also, of course, maintaining good sanitation is a must. Next slide, please. There are also several interventions that we can be implementing for all migrant, refugee, and displaced populations, and these are adequate supply of personal protective equipment, linguistically and culturally appropriate health education, and risk communication. So, for instance, production of informational materials in multiple languages will be very important. And we should have effective outreach approaches. So we should be involving community leaders, cultural mediators. We should be using hotlines, social media, or mobile health technologies to reach out. Next slide, please. Universal health coverage is very important. Access to testing and treatment, regardless of legal status, is very important. And also, field hospitals and mobile clinics can create significant difference. So although few members, some countries actually announced that they will treat asylum seekers as permanent residents, allowing them to access public services during this outbreak. Decreasing stigma and discrimination, especially via media tools, is very important during this outbreak, and community participation. So involvement of migrants and refugees in planning, implementation, and evaluation of COVID-19 related policies and practices is important. While implementing these interventions, of course, intersectoral collaboration and sufficient funding, resource allocation will be important. So cash transfers will save lives, especially for migrants and non-migrant people who lost their jobs during this outbreak, and for families who need financial support. So in summary, next slide, please. All countries need to have a human rights-based and inclusive approach that leaves no one behind to control the COVID-19 pandemic and to promote health at the global level. In this respect, international organizations have a very crucial role to guide countries and to show them the best practices. We should remember that inclusion of migrants and refugees in all policies is also crucial to achieve SDGs. Thank you.
Thank you so much, both of you, for this presentation. And we have a few questions, so we can start taking some of them. Just for instance, we can read this one. This is a question for Dr. Zamora and Carmen. So do you expect national restrictions to immigration can be maintained or strengthened, thereby severely constraining international migration in 2020 and beyond?
I'm sorry, can you please repeat the question? Because we can't see the question.
Absolutely, yes. The question by this person is whether you believe that national restrictions on immigration will be maintained or strengthened, and thereby constraining international migration during this year and beyond.
Okay, maybe I can take that one. It is unfortunate that I believe some countries are going to be using the COVID-19 pandemic in order to restrict entry into their national territory. So there is no way to know how the situation will evolve. It is very possible that from now on, even regular travel is going to be affected. A lot of countries that will have gone through the pandemic and will have succeeded in containing and stopping it will probably require all travelers to be quarantined at least 14 days before going into a country, which for a lot of business travel is going to be quite difficult. And I do believe that some nationalistic countries will use this opportunity to close their borders for.
Thank you very much. I have another question here, suggesting that obviously with the total economic shutdown in many countries, which is not sustainable over time, some countries are considering just keeping those vulnerable protected and continue with the rest of the population business as usual. So is asking, what is your view on this? And I think this might be a good question perhaps for Dr. June, Dr. Bresa, or Professor Chakur. Anyone?
Okay, in my opinion, I'm sorry.
Yeah, go ahead, please.
Sorry, please, Carlos.
Can you please restate the question, Florencia?
Absolutely, yes. So the question states that obviously with the total economic shutdown, it's not sustainable to keep it over time. So some countries are considering to just keep those individuals that they are vulnerable protected while keeping the rest of the population business as usual. And what is your thought about this?
Well, this was in the original UK strategy, if you remember. So the most receptive population to develop the severe disease is the population that is above a certain threshold age or that has some comorbidities. This could help reduce exposure, but has exposure of this population and hence severe disease and hence load in the health system, but it has enormous implications for the well-being of these people, and in some areas might be impossible. Remember what I showed, that in Spain there's 10% of 3 generational households. So this could contribute, but I think we have to understand that we might have to change several of our the measures that we take in our daily lives. We will have to change them for a long period of time, if not forever.
Thank you, Carlos. Another question for you. It says, is Spanish expected to have only more cases and also more death than China and Italy? Why is such an extensive spread and death toll?
Well, I think the answer to why did it spread so quickly is because the actions were taken in a stepwise fashion. It was first closures of schools, and then we had some social distancing, and then an initial lockdown that included work mobility. I think when you're dealing with exponential growth, if you take a humble approach or a step-by-step approach, at least in the experience we're having here, it seems not to be enough to bring R0 below 1 and reduce this epidemic spread. So this stepwise approach may have contributed to it, but also I tried to put in my presentation that there's other things, right? There's the population pyramid of Spain, the intergenerational households. So there are many things that have contributed to this. I think we will have to study post hoc.
Thank you, Carlos. And there's a question here that is just a perfect follow-up for that one. If you want to take that one or any other speaker, it says, if the stepwise approach is not sufficient, what would it be the recommended if we move to an exponential growth of cases?
I think many countries have seen this experience in the north, and many countries in the global south and others have taken a much stronger approach from the beginning. And there's countries already going in lockdown with very few cases and no deaths. So it will be in the next few weeks that we will see whether this early lockdown has effectively contributed to reduce the epidemic spread in the early stages. But the challenge is not that. The challenge is that people who have not been exposed in the absence of a vaccine remain susceptible. So the challenge is finding strategies that are sustainable in the long run until there is a vaccine available that is effective and deployed.
Thank you so much, Carlos. So here I have a question for Dr. Jun, which says, I just lost it for a minute here. How was Korea able to implement such a system of social distancing and containment of the virus without a large-scale deployment of uniformed personnel? Dr. Jun, if you're available. Maybe not. Well, then I think we have one more about migrants in camps, and it says Human Rights Watch is already documenting discriminatory measures against them. How can the international institutions ensure that they are not left behind? Sorry.
So international organizations and humanitarian organizations, NGOs, can you hear me?
Yes.
Okay, perfect. So international organizations, non-governmental organizations, and many humanitarian organizations have an important role, and governments, decision makers, media, all have a role, I think, in decreasing stigma and discrimination and making sure that no one is left behind. So increasing awareness about the vulnerabilities of especially forced migrants, undocumented migrants, people living in camps, detention centers. Increasing awareness is very important, and increasing awareness about the fact that we should be including everyone, or else no one will be safe, is very important. So the safety of migrants and refugees is also important for the safety of host societies. It's very important to make emphasis on this, and also it's very important to decrease stigma and the false belief that migrants are the cause of this outbreak. It has no scientific evidence.
Thank you very much. And a last question, if Dr. Jun, if you are now unmuted, perhaps. Dr. Jun? Hello?
About social distancing practice in Korea. Sorry about the connection difficulties earlier. Actually, the Republic of Korea cover their citizens and their refugees also for under their coverage of the universal health coverage. If they want to have some diagnostic test for some kinds of the COVID-19 or some other healthcare services, and in the admitting their hospitals and their quarantine services, everything. So we are trying to keep this policy, and we don't have the policy. No one. We keep our policy. No one behind this situation.
Thank you very much. So we're done with this session, and we thank you so much, all of the speakers, for the insightful presentations and answers. We would like to divert a bit from the agenda, since we were trying to bring on board Patrick Ovayaji. He's the health Director General of the Ghana Health Service, and we were able to connect. So we will appreciate if you could give us a very short statement, perhaps 2-3 minutes. We will really appreciate to hear from you. Thank you.
Well, thank you very much. Ghana, since the 12th of March, started getting cases, and we have moved from the first 2 cases on the 12th. Currently, we are doing about 137 cases, and that's at this moment. I'm sure by the end of the day, we'll have a few more cases. We have had to implement a series of measures, starting from restricted entry into the country, closure of borders, and now we are currently under a partial lockdown. Ghana cannot do the total lockdown because of infrastructure deficiencies such as water, access to public latrines, and food security. So we are currently going to have a 2-week lockdown, primarily to follow up court cases, do a lot of contact tracing, and also do testing and do some basic environmental surveillance to see what are the evidence. We've so far have a very few cases where we cannot trace it to travel. Most of the cases, more than 95% of the cases, are people who have traveled into the country. We have recorded 5 deaths, people who are aged and with comorbidity. So far, we have a couple of treatment centers across the regions. We currently earmarked about 520 beds across the country for COVID management. But by and large, we are managing most of them at home now under strict supervision in collaboration with the national security so that we can ensure appropriate self-quarantine. So broadly, this is where Ghana is. We move into an early lockdown, hopefully to curtail transmission and also reduce, identify those cases and follow them aggressively, their contacts aggressively, and intervene. I say partial lockdown because we are currently doing it more in 2 main cities where we are recording cases. That's Accra, the capital, and the second capital, Accra, just like Nigeria is in Lagos and Abuja.
Thank you so much, Dr. General. We really appreciate that you were able to connect and share with us your updates. Please stay in the line as well so you can be part of the discussion.
Yeah, thanks for inviting me.
Thank you very much. Well, moving on the agenda, now we are starting part 3 on the economic impacts and economic management of this epidemic. I'd like to invite Professor Jeffrey Sachs once again, so he shares his presentation with us. Thank you, Jeff.
Thank you very much. When we come to the economics, we're talking about something really unprecedented. In most economic management, we're speaking about how to keep the economy moving and even achieve economic growth. When we come to the economics of COVID, we're talking about, in the short term, the intentional closure of much of the economy. I don't remember any kind of comparable experience in modern economic history where the goal is actually to systematically shut down parts of economic life for the sake of epidemic control. In this sense, we are in uncharted waters. Terms that are used, such as stimulus, make little sense because they are the residues of usual economic practice to boost an economy. We are in management of partial shutdown and then economic recovery. So let me discuss that if you move to the next slide. The main policy issues with strong fiscal, that means budget implications, are first and most urgently to break the epidemic. We have been discussing the steps of closing the economy, keeping people at home, shelter in place, national shutdowns, lockdowns, quarantine, whatever word we use for it, to stop the transmission of the disease itself. The second major policy issue in the short term is bolstering the medical or hospital system, the care to keep people alive. We have already heard the dramatic pressures on hospitals, the need for protective personal equipment that does not exist, the fact that there are hospital-related incidents of spread of the disease, much less patients dying for lack of ventilators or other care. The third major policy issue is building the public health capacity. It's important to distinguish between the hospital clinical capacities for sick patients and the public health capacities to monitor, test, trace, and isolate cases of infection. These are public health preventative measures which are essential for controlling the epidemic. They are distinct from what is happening within the hospitals. The fourth major fiscal implication is protecting the vulnerable. The vulnerable include at least two classes of vulnerability, though they overlap. One is the vulnerable to high risk of disease and death, especially the elderly and people with existing medical conditions, pulmonary, cardiovascular, diabetes, and others. The other vulnerability are people on the margins of society that have no reserve, the poor, the indigent, the self-employed who lose all incomes, the refugees that we heard about. The fifth major challenge to mention is financing this period of emergency response. The sixth is the economic challenge of restoring economic activity as soon as possible. The logic is partial shutdown with a planned phase back of the economy, but not too soon, after it's possible to control the epidemic through public health means, because the level of infection has gone down sharply. The seventh area of major policy issue with fiscal implications is the research and development for new therapeutics and vaccines. Next, please. The most urgent fiscal needs are for frontline medical services, both the financing and the procurement. We're having huge struggles with both the financing and the procurement of the frontline medical services. The second major fiscal need is social support during the lockdown period. What do I mean by that? First, to make sure that everybody has the basic means to stay alive. That is food provision, water provision. If you take medicines, the continued flow of medicines, shelter, safety, social services to ensure that people who are isolated don't die of their isolation. And so we need both income flows for people who lose all income, such as in a formal economy, unemployment compensation, and in an informal economy, some kind of transfer payments or a direct food subsidy. And we need the social support of public services for the frontline response and to keep public safety. We need urgent financing for states and cities below the federal level, because states and cities everywhere are on the front line of manning clinics and hospitals, of emergency workers, of unemployed and dispossessed, and so on. We need financing for national budgets for all of these needs. And then we have the urgent question of financing companies. Two kinds of companies: those that are vital for the supply chains so that we don't have a collapse of infrastructure, we don't have a collapse of transport, we don't have a collapse of food provision around the world, and companies that are shut down that have major burdens of debt and payrolls and rents and other fixed costs while their income has disappeared. Next slide, please. It's important to have in mind that our shutdown phase, which is extreme, should last no more than 2 to 3 months to bend decisively the epidemic curve and bring the infections down to a low level that can be followed by public health means rather than shutdown means. So the first stage of the shutdown is to cut the prevalence of the virus from perhaps 1 per 100 infected down to 1 per 10,000. These are rough numbers, and since we don't test most cases, we don't know the current rates, but we need to shut the amount of infected people relative to population decisively during the first 60 to 90 days. Next, please. In New York, there are an estimated 35,000 confirmed cases out of 10 million, just as an example. That's perhaps 300,000 actual cases, or 3 per 100. During this first lockdown phase, this should be cut sharply to perhaps 1,000 cases, or 1 per 10,000 of New York population. That's the kind of example that I have in mind. Next, please. The follow-up stage has to be targeted to keep the epidemic under control even as the economy starts again. And that means very aggressive public health systems with contact tracing, with isolation of infected individuals, and with other means to stop the return of the epidemic. In other words, we have to keep the effective reproduction rate far below 1, at least below 1, even as the economy returns. Next. The final stage is a development of therapeutics, and ultimately, we hope a vaccine within 2 to 3 years. But in this middle phase, it is to reopen economic life, but without a resurgence of the epidemic. Next. The shutdown stage, if properly done, should not last more than 90 days because we can break the transmission during that period. The output losses in the economy during that lockdown phase could be in the range of 20 to 40% of total output, for example, as measured by the gross domestic product. Tax revenue losses could be even larger, even half of normal tax revenues during this period. The annual output losses as conventionally measured, if this is managed properly, could be 10 to 15% of GDP, unprecedented. The largest declines absolutely ever experienced in modern times, at least since the Great Depression. Tax revenue losses for the year could be 20% or larger. These are all very rough guesstimates at this stage. Next, please. Budget deficits will therefore soar to more than 10% of GDP in most places, up to perhaps 20% of GDP, at least for some quarters. This takes into account the need for more public spending and dramatic losses of revenues. So the most important fiscal question is how to finance these massive budget deficits and cuts, and how to reduce the period of economic losses to the maximum extent possible with the containment of the epidemic. Next, please. Other economic challenges, in addition to the fiscal or budget challenges, are protecting vital supply chains, food, medicines, essential equipment, maintenance, infrastructure. It is the procurement of urgently needed equipment, for instance, the ventilators, the masks, the protective gear. And it is preventing a financial crisis that results from the new debt burdens on governments and on companies that could lead to a cascade of bankruptcies or credit runs, which would dramatically worsen the economic outturn even beyond the shutdown period. Next, please. So some emergency financing instruments are vital. Governments should borrow large amounts. Rich country governments can do this on their national or regional financial markets. The IMF, we'll hear in a moment, has introduced instruments, rapid financing instruments, rapid credit facility. Now it's currently at a modest number of some tens of billions of dollars. The IMF's capacity is perhaps up to $1 trillion. We don't know how much is needed right now. We're going to hear from the IMF shortly. We need urgent multilateral development bank concessional financing. The World Bank, the Inter-American Development Bank, the Asian Development Bank, the African Development Bank, the Islamic Development Bank, and others to be providing urgent COVID financing. This can't be 6 months, 9 months, 12 months of planning. It has to be immediate, because in an epidemic, it is days and weeks that count, not months. It has been proposed, and I think strongly recommended, that there should be a standstill on sovereign debt of developing country debts. Both the IMF and the World Bank leadership has called for this. This is something that needs to be decided in days, in fact, again, not weeks or months. Finally, central banks have recognized that they have the essential role of keeping liquidity and of refinancing commercial paper as well as sovereign debt, as well as providing interbank swap lines so that no country runs out of foreign exchange, which is so easy to happen in these circumstances. So central banks are also in the front line. Thank you. Next. We need to avoid a self-fulfilling financial panic on government and corporate debt. Suppose Standard & Poor's and Moody's and others starts writing down debts and then makes it, by those write-downs, administratively impossible for pension funds and banks to continue routine rollovers of those debts during this period. The result would be that you turn an epidemic into a financial catastrophe, which would greatly amplify the economic crisis. So we need, in other words, macroeconomics, monetary policy, fiscal policy, all to accompany the shutdown period. In principle, the shutdown period by itself, 60 to 90 days, and then a return to, quote, normal, would be manageable. It would be unusual, it would be painful, but it's manageable, a short-term shutdown. Of course, it is profoundly difficult in the midst of a massive disease burden, massive threats of infection, many sick people, highly vulnerable people who are not protected. But it is also the case that we need to plan the post-shutdown phase now, to be taken over by public health and to prevent there being a cascading financial catastrophe that would turn this from a public health catastrophe to a financial catastrophe, because that would multiply the economic costs many-fold, and they're going to be high enough. Next, please. That is the end of my remarks. I did not offer any specific numbers because these are general principles that are different in every specific context. It is uncharted territory. We must move very fast to ensure that budgets and financial markets remain open and working, especially in this emergency phase, and that we prepare for a quick exit from this phase, not just by an arbitrary 60 or 90-day lifting of the closure, but by the replacement of the closure with public health control, which is cheaper and much better targeted. Thank you very much.
Thank you so much, Jeff, for this. Our next speaker now is Yuning Gao, is Associate Professor at Tsinghua University School of Public Policy and Management. Please go ahead, Professor Gao.
Hi, it is my great honor to be invited by STSN to share our most recent observation about the COVID-19 on China's economy. So today, next slide, please. I would like to talk a little about the impact of COVID-19 onto Chinese economy and what are the most recent policy response to the economic impact. So next slide, please. As China is the first economy that was seriously affected by COVID-19, so we have already experienced a serious economic lockdown, and also almost all sectors are seized as a reaction to the fight against the COVID-19. So let's first see the Financial Times China Economic Activity Index. That actually gives us a very clear contrast against the Spring Festival of China in 2019. Now it seems, for example, the power plants only recover roughly, 2/3 of their capacity of the electricity generation, and let's say other business activities like container flight, traffic congestion, and they are all just roughly, 2/3 of the activities in the same day after the Spring Festival of 2019. And no doubt, just as the release for space sales and also the box office submission for cinemas. But no doubt there is a byproduct that the air pollution of China is also slowing down. It's roughly, more than a quarter of carbon dioxide emissions kind of disappear compared with 2019. Next slide, please. And this kind of, economic slowdown will give us, the impact or the numbers that the Chinese economies are actually totally seized on not only the demand side, but also the supply side. So this is kind of not the activity that happen frequently in our economic textbooks. So now, just as Professor Sachs mentioned that we are now just experiencing the first step of recovery. You can see that for the first 15 days after the Spring Festival, only a very few plants and factories are recovering, whom, for example, the mask producers and the food suppliers. And then 1 month after the Spring Festival, you can see that the government has started to encourage more and more business to recovery. But at that time, less than 50% of the economic activity can be recovered. And just as Professor Sachs mentioned, that we kind of seem to have a kind of economic shutdown for roughly 60 to 90 days. So now the expectation of this kind of recovery is that for the next 60 days, and then our industrial productions can be recovered, and roughly 90 days, and all other offline services like catering and travels and maybe can be gradually recovered from this disaster. So next slide, please. So all these kind of lockdowns, starting from Wuhan and then Hubei and then total China, and let's say these kind of seized in both supply side and demand side actually caused a very deep V in China's economic growth during the first quarter. So the first group of entities are highly injured are actually our small and micro enterprises. So this is a survey from a lot of economists saying that you can see that roughly half of the small and micro enterprises said that their revenue will less than 10% or even more in this year, and roughly half of them, their cash flow can only support of their operation for less than 3 months. And on average, they expect that roughly 15% of their employers will be laid off during this whole year. So that's a very big number, because small and micro enterprises, they account for nearly 60% of China's total employment. And there are roughly, 18 million these kind of enterprises all around China. So next slides, please. And you can see all these kind of slowdown and shutdown of the enterprises, the business operations and economies actually caused very deeply in the first quarter of Chinese economic growth. So all the numbers we can have is just negative, negative, and negative. So not only, let's see, the industrial value added, the fixed asset investment, the whole society, the retail sales, they are all negative. So you can see the numbers I listed here, they are all negative 13, negative 20, and negative 24%. So that's never happened in Chinese economic growth during the past, let's say, 3 or 4 decades. Even, let's say, the total export and import, they are also experienced a negative growth. And so for the first 2 months, China experiencing a very significant trade deficit for less than, that actually happened just maybe once during the past decade. So during all these things, the significant number is that here, our so-called surveyed urban unemployment rate now is kind of more than 6%. This is actually a big number because during the past decade, this number is always, roughly just 5%. Although maybe 1% sounds not a big number, but please remember that, the total urban employment of China is kind of 440, let's say, million. So that means 1% is actually 4 million employees lost their job position. So next slides, please. So that's why, this year, our main target of macroeconomic policy is trying to stabilize employment. So the central government now try their best to, or use all different kind of macro policies to, either to have more fund raised for the micro and small enterprises, either, they directly issue even, let's say, the vouchers for the, the individuals. And therefore, this is actually the way, the Chinese government try to help to keep the unemployment rate low than that. So next slides, please. Okay, yeah, so this is just a number. You can see in history, China's so-called surveyed unemployment rate is usually just roughly 5%, but now it's nearly 6%. That means an extra 4 million people lost their job. So next slides, please. And on the sector's estimation, you can see that, this is the estimation from my colleagues. So the previous one shows you that let's say, the catering accommodations and let's say cinema, all these will experience let's say a negative growth for roughly 10% or even 17%. And only, the public health and these kind of industries can still experience positive growth. So here we do a simulation, use the global model, showing that just the first stage, this is actually not based on the pandemic recently. This is just based on the epidemic inside China and the cease of the supply chain inside China. And that shock, you can see outside China, well, already, leads to a slowdown of not only textile, wearing, rubber, plastic, ferro, non-ferrous metals of all these economies have experienced a kind of, a slowdown of negative 0.6 to 0.8%. But let's say now, if you consider the pandemic worldwide, this number will definitely be much larger than that. So next slides, please. And now, what's the response of Chinese government? The recent, the central government has already announced first 500 billion yuan quota for the refinancing and rediscount from the central bank to directly support the small and micro enterprises, and to because all of them are actually scarce of their cash flow, so they actually can get these extra monies. Second is that only the first 2 months, the local government has already used up roughly 2/3 of their quota for the total whole years, the local government bond issuing. And besides that, just on Friday, last Friday, the central government has also announced that we should issue a special purpose to central government bond. Roughly speaking, it's 1 trillion yuan, but maybe today the news I heard that some scholars even suggested to 2 trillion, even 3 trillion yuan totally. because that's actually out of the general budget deficit. So this special purpose central government bond can actually refinancing the whole fiscal system and give them enough money to use. And finally, is that they also announced that we should have inside China, we should have new land policy that allow 8 provinces, including the Beijing, Shanghai, Chongqing, and Tianjin, the 4 municipal cities, are allowed to turn their so-called permanent basic farmland into construction land. Means they can use this farmland to development property market. So this is actually also for the first time the provincial level government are allowed to use their own land policy to boost their property market, and also use for even for example the industrial land use, all these kind of things. So this is actually another way try to give the local government more flexibility to try their best to fight against economic the shutdown, and to try their best to recover that. But overall speaking, no doubt, my first the conclusion before the last slides is that first thing is that the deep V of Chinese economic growth for the first quarter will definitely lead China's economic growth to 0 or near, let's say, negative growth for the first quarter. So I think that's actually never happened during the past 3 decades or even 4 decades. So finally, the last slides, please. You may also see that not only the central government said they need to issue the special purpose central government bond, but also you can see all the provincial level government has already announced that they should have a midterm investment projects. The last slides, please. The investment projects for the next 5 years, and totally the number we got now is nearly 50 trillion yuan for the next 5 years. So at least for this year, the investment projects should be roughly near 8 trillion yuan by then. So this kind of infrastructure will use more on these kind of projects. We call them new infrastructure, let's say 5G, ultra high volt grid, and all these things. So we, including, you can see the Hubei province, they also announced that during the next 5 years, they will have roughly 900 new projects for, let's say, more than 3,000 billion yuan for their investment projects. So this is actually maybe the thing that the China central government and local government can do to fight against the total economic shutdown, and to try to hedge the negative impulse of COVID-19 maybe for the next several years. Hope the second half of this year we can compensate the part of the loss. But totally speaking, this year maybe China will experience extremely low economic growth. So that's not a surprise, because we have already experienced a very deep V during the first quarter and maybe the first half year of 2020. So that's actually the main information I would like to share. And thank you for your time.
Thank you very much, Professor Yuning Gao. We would like now to invite our next panelist, Martin Muehlisen, Director, Strategy, Policy and Review Department of the International Monetary Fund. Thank you, Martin.
Hello, everybody, and thank you very much for inviting me to this panel. Let me give you a bit the IMF perspective of how the last couple of weeks have looked and what we're doing to help with this global shock. Already it has been discussed that the combination of the health shock and the uncertainty about how long the virus will last and how it can be best contained or reversed is adding a lot of strain to the economic shock that is now unfolding. And in the first phase, I would say, following the example of China that we have observed, the fund has talked to the, especially the major advanced economies about the policies that are necessary to stabilize their economies after the onset of the shock. You may have seen the short paper that our managing director has put out, I think it was already 2 weeks ago, which seems almost like an eternity, And since then, the advanced economies have responded, as Jeff has noted, with major fiscal stimulus, with measures to support the financial sector. And it's been unprecedented, going in some instances way beyond what happened during the global financial crisis, for example. Now we have a bit of a sense of stabilization in the advanced economies, which is important, I think, for the global economy as a whole. But all the while, we've, of course, looked very much into what does it mean for emerging markets and developing countries that don't have the resources that the advanced economies have. Many countries are, or there are not many countries that are in a position to put up stimulus programs of 10% of GDP or more, or kind of finance deficits of that amount. And indeed, what we've seen is like a triple or quadruple shock that has hit many emerging markets and low-income countries. There's the demand shock from the main customers, so to speak. There is the financing shock with large capital outflows already being observed. And then there is, for many countries, the shock of the commodity prices, where revenues are falling away. And then on top of all that, of course, many of the countries are not in a good position to deal with the health shock that's now unfolding slowly, as we can observe. There are many relatively weak health systems, and above all, difficulties to obtain the necessary medical supplies and equipment that's needed to fight the crisis. So it is quite a shock, and obviously we all can't remember anything that has happened on that scale before. Now, the fund, of course, the IMF is not in the business of supporting health system per se, but we have worked very closely with the World Bank, with the WHO, with the multilateral development banks, to coordinate on the rescue. And my kudos here go to the colleagues from the other institutions that have worked very intensely to try and address the issue of the medical supplies. What we've been doing at the IMF is we're helping countries now deal with and prepare for the onset of the pandemic, and to deal initially with the economic shock that they've experienced. There are large financing gaps opening up, and for that type of problem that is kind of mainly due to an exogenous shock, we have two windows with which to respond, which are commonly known as the emerging financing facilities of the IMF. What they are is, you can imagine, as you know, the IMF has a credit union where each member has a share, which is, in our case, called the quota. And these rapid financing instruments that we have already had on the books, they allow countries to withdraw or kind of exchange their own currency from the fund up to 50% of their quota in 1 year, in one go, in hard currency. And so that is kind of the yardstick with which we assess the financing capacity that we can provide through that particular window. The advantage of this particular window is because it's an emergency financing. The requirements that the fund usually puts on its lending instruments are not quite as stringent as we have them for our normal programs, where, as you know, we need to close financing gaps within a program period. We need to see the reforms that lead to that, and we need to have all the co-financing sorted out so that there's no gaps. In the context of these rapid financing instruments, what we do is we essentially ask the country to explain to us how they intend to respond to the underlying shock. In this case, how they intend to respond on the health side, and then we need to kind of look at the debt situation of the country and make sure that even with the shock, we can assess that debt will remain sustainable. And I'll come back to that in a second. This, in a sense, is really the only binding constraint for some countries, except other constraints that, for example, restrict us from lending in the case where countries have arrears to the IMF or other international institutions. But that financing window is available, and as you know, we've already gotten a lot of requests. What I should say is that for countries that are eligible for what we call the Poverty Reduction and Growth Trust, for them there is a separate window that is kind of very similar. It's called the Rapid Credit Facility. The difference to the facility that's available for all members is that this particular window, the so-called RCF for low-income countries, has better repayment terms and has at the moment a zero interest rate. It is part of our facilities that are there to help especially low-income countries with access to financing at better terms. It is financed through a trust, the so-called PRGT, Poverty Reduction and Growth Trust. And that trust kind of lives off contributions by member countries, and it is used to subsidize, if you want, the interest rates and the repayment terms relative to our normal instrument. And again, that PRGT plays an important role, and I will come back to it also. So what we have seen now in the last 2 weeks is that a very large number of countries, more than we probably ever had at one go, have availed themselves of this of these two windows, both the so-called RFI and the RCF, also a mix thereof. We've had about 80, actually more than 80 countries now that have asked for support, and if you add up all the requests, we're currently somewhat above $20 billion. We are trying to process these requests as soon as we can. In fact, we just had a discussion at our executive board to adopt streamlining measures to reduce the time it needs to process these programs from somewhat like 4 weeks, 5 weeks, or even a bit less than was the average in the past, to something like 2 to 3 weeks. The reason we need to kind of still look at them is what I mentioned, the requirement of debt sustainability. But these are not your typical IMF programs. I mean, these are very short papers. They are all done remotely because everybody is working from home, and so do we. Simply having them kind of internally processed, that doesn't take very long, and then it has to go to the board where people actually have to read the papers. They have to get their buy-in from capitals, and then they will be decided as quickly as possible. So we had the first of these requests through the board last week on Thursday. It was the Kyrgyz Republic, and they received, let me just check here, they received about $80 million, which is a third of their quota through this window. The reason it was in this case 33% of quota, as opposed to what I said earlier, 50, is that we already do have some other programs under the PRGT with various countries, and we also need to look at the financing needs of the country itself. And there is an overall annual access limit that applies to all of these windows. And so sometimes countries already have programs with us, and that explains why sometimes in some cases the loans will be a little bit less. Now, what we're doing right now, in addition to processing all these requests from countries, is that we're also discussing with our executive board ways to increase the scope of these emergency financing windows. We're discussing, for example, whether we could increase the size of them. For example, there's discussions whether one could go up to 80% of this quota or 100% of this quota. I think the mood in our executive board has been to move on this fairly quickly. However, the issue here is twofold for especially the low-income countries. One is that the large number of requests and the follow-up programs that will probably be necessary down the road will require quite a lot of the resources from this trust fund that provides the subsidized terms for low-income countries. And too large of an increase at the moment could mean that the fund is pretty fast going to be emptied, and we're by our rules required to maintain the self-sustainability of that trust. Now, that is something we need to discuss with the membership. We need to have a package that provides confidence and quick help to our members, especially the low-income countries, but we also need to make sure that we can finance what we promise. And so our room to increase here our rapid financing access is a little bit circumscribed by the financing envelope. Then, as I mentioned before, we have to look at the issue of debt sustainability. And as we know, many countries, because they're hit by that shock, will have their fundamentals deteriorating quite a bit. And how long that shock will be in place and what the situation will look after the epidemic is over will determine, of course, our view on the debt sustainability itself. It's very uncertain at this point to make these judgments, and we are not intent on holding up financing requirements. But there are some countries where it's going to be difficult to conclude that that will remain sustainable. Some of them countries are already in debt distress, for example. And therefore, the initiative by the World Bank and the IMF that came out the other day to have a type of moratorium in place to have official bilateral creditors forego their repayments for the duration of the crisis is a very important element. To the extent that countries can use the resources they need for medical spending and to fight their economic problems rather than repay creditors would be a very important part. What we hope is by our spring meetings in the coming 2 weeks to have a package ready that we can present that addresses some of these issues. And then, of course, we will need to go beyond the emergency financing and look at the more medium-term challenges that will emerge both for low-income countries and emerging markets. Thank you.
Thank you very much, Martin Mulayson. We will now address some questions. So thank you so much, everyone, for those insights. So here we have a question for Martin. So for the IMF, saying like concerning the sanctions toward the countries like such as Iran, for instance, could Iran be eligible for any financial tools for the IMF, and how the G20 countries that the IMF are coordinating to fund Africa? Is there any specific package given to Africa and the South Asian country?
Thank you. Iran, like every member, is eligible for the for these instruments, and we're discussing currently with the authorities how to proceed. On the question of the G20, the leaders' call that happened the other day had a discussion how to help Africa specifically. Many of the countries that benefit from the rapid financing instruments that I just mentioned are in Africa. And I think there's an awareness that, especially in Africa, health systems are in many cases quite weak. So that's really a focus of our efforts. But of course, there are low-income countries and countries with weak health system also elsewhere. But clearly, in Africa is a large focus of our operations, I would say. And you may have read or heard about the blog that just came out by our African director, Abe Selassie, who describes the situation in quite stark terms. Thank you.
Thank you very much for that. There is a question here for Professor Sachs. It says, the world needs a big amount of funds to recover. So we all know there are lots of money in the offshores, It means like no paying taxes. So is this the right moment to finish with these scandalous and unfair offshores and fiscal paradise to help the world to recover?
First, let me thank the other members of this panel. Wonderful presentations by Professor Yuning Gao and by Martin Mullison at the IMF, and I want to thank them for their leadership. I want to say one word about the IMF. It is our core global macroeconomic institution, the most important in the world. And we need the member states to understand and the board to understand that we are operating in hours and days, not weeks and months. Debt sustainability, which is very important, cannot be the criterion for making immediate finance available for fighting an epidemic. We clean up later. Of course, the IMF is a very principled organization and a very proper one, but the board needs to understand the urgency. When governments are shutting down, when they're voting $2 trillion or mega packages for themselves, they have to understand that for the poorest of the world, the conventional accounting standards of debt sustainability will lead to mass death if those are maintained. And so I just want to make an indirect appeal to the board of the IMF to understand this is different. And the IMF is the frontline institution for the whole world in this. This means also in thinking about issues of debt sustainability, we need a urgent rethink because a lot of this debt is going to have to be canceled. A lot of the current debt service is going to have to be suspended. We need a debt standstill for low-income countries urgently right now. Everything is different right now, and we don't have time for academic debates. We are in the front line of this crisis. Also, to add on the economics, the faster one addresses this, the dramatic reduction of the overall cost. That's the nature of exponential growth. Get it early. If we wait, and we have waited, it becomes explosive and everything becomes much harder. So the IMF board needs to understand, stop the debt sustainability criterion, open up the spigots for financing related to urgent pandemic response. For the longer term, we're going to have a pile of debts. Some are going to have to be written off. Some are going to have to be financed through increased taxation. The increased taxation is going to have to be borne principally by those of means. And that means that these tax havens, as the question implied, are all the more obnoxious right now because they were a scandal beforehand, but now the rich are going to have to pay for what they haven't paid before. And get ready after all of this mega spending, which we need for rising taxes on wealth and on higher incomes so that we can keep the governments afloat for the longer term. This is on its way, and it's not the business of today. It's not the business of next week. It's not the business of next month, but it is the business of the coming years, because the mountain of debt that will arise from this will be very, very large. Finally, I want to commend China for having this remarkable experience of creating this V consciously, break the epidemic, then start to lift the restrictions, but without allowing the epidemic to resurge. And then think about the longer term and that list of longer term actions, 5G, ultra high voltage transmission grid, fast rail, e-vehicles, big data, artificial intelligence. These are the sustainable industries of the future. So this is another commendation to China's approach. And I think others should think about how their green deals will follow the shutdown and then the restart of our economies. Right now, emergency, but yes, we need to plot out step by step the following actions. Thank you.
Thank you very much, Jeff, for those considerations. There is here a question which you touched before, but I think it's particular focus on developing countries. It says, one of the main suggestions of economists is to set aside macroeconomic targets to first focus on how to finance the response against COVID-19. But as we expect the global recession due to this crisis, how can developing countries respond to this economic recession and achieve their macroeconomic targets of growth, unemployment, and inflation once again?
Maybe Martin, if he's on the line, can also address this, and of course, Union Gao can address this. But the key is to keep the shutdown phase as brief as possible by being very effective. Break the epidemic. Follow that with public health measures to stop the resurgence once the number of infections is dramatically reduced. That's the first thing. We need a V. It means sharp down, but then recovery in a limited amount of time. In the interim, this emergency financing is essential. And then we're going to need to clean the books because there's going to have to be a lot of debt write-offs for poor countries. This is obvious. This is a shock unseen in the last century, basically, since the Great Depression. And the scale of this is absolutely enormous. So early finance, stop debt servicing, get money to where it's needed, make the recovery as fast as possible, and then expect the cleanup of the balance sheets. And don't let this turn into an ongoing, prolonged balance sheet crisis like in 2008, because that, and we just must avoid that.
Jeff, if I may come in with one word, just to support a lot of what you said about the economic policies that are needed. I can tell you that our membership is also working with great speed toward addressing many of the issues you mentioned. We've already seen after the large packages that advanced economies have passed, that also on the international level, the mood has shifted quite a bit. And in fact, there is a cooperation that is quite extraordinary. There's still a lot of work needs to be done, but I think what you said about the dimension of the challenge, it is sinking in across the membership, and we've had very productive discussions at the board. That's perhaps all I can say at the moment. Thank you.
Hi, I think I just would like to have a last sentence on that. I would like to just quote the saying of our Prime Minister Li Keqiang 2 weeks ago. He said, "This year, China's only target for our macroeconomic policy is to stabilize the employment, no matter the number of economic growth." So I think for mostly developing economies today is that we should people on the first priority, how can they still get their life goes on, and don't care too much about the total number of economic growth. So I think that's maybe the sentence I would like to quote.
Thank you very much, all of you. There are many other questions related to what you have discussed in terms of the instruments what the governments can use, which I think we touched a bit. And also there is much interest on how this will affect middle income class, particularly. I don't know if there's any additional comments that you would like to discuss on this, and also on the role of the official development aid and multilateral development banks. Anyone that would like to add to this? Perhaps any final word, so we close the panel and we move to part 4.
Nothing from me, but thank you very much for inviting me. It was a pleasure talking to you.
Thank you, Martin and Yuning, for being with us. Everybody really appreciates your wisdom and your leadership in this area for both of you.
Thank you.
Thank you so much to our wonderful panelists, and we're moving on to part 4. We're going to now focus on the prospect and on treatments and vaccines. And our next speaker that we will hear from is Rino Rappuoli, Chief Scientist at GSK Vaccines. Rino, please go ahead.
Okay, can you hear me?
Yes.
Hi, can you hear me?
Yes, absolutely.
Loud and clear, and very eager to hear.
Perfect. Well, thank you for inviting me to talk about vaccines today. As you said, I'm Chief Scientist at GSK Vaccines, but the presentation I'm going to make today is not the position of GSK, it's my personal position of what the situation is to make vaccines for COVID based on my experience. So it's my personal views. Now, when we talk about vaccines, I think we used to make vaccines for viruses and for other pathogens, basically growing viruses, killing them or attenuating them, and that used to take a lot of time. Following the genomic revolution, it has been possible basically to make synthetic vaccines. And probably the first paper where the very fast development of vaccines in the laboratory happened was something happened in 2013, 7 years ago. At that time was a similar situation. In China emerged a new potentially pandemic influenza strain called H7N9. And on the Easter 2013, on the Easter day, the China CDC put the sequence of the agglutinin and neuraminidase on the internet. And we started a day, at that time we were collaborating with Craig Venter. And basically on day 2, Easter Monday, we started making synthetic gene. And to make long story short, by day 7, we had an RNA vaccine ready to go into mice. So that's the kind of revolution that happened thanks to the genomic and synthetic biology. Today, you don't have to ship viruses, you don't have to ship things. You can make vaccines based on the information you can get on the internet, make synthetic genes and make RNA vaccines or other things. So that was done 7 years ago. At that time, this was a kind of pioneering thing. Today, this speed can be more or less is available in every lab, academic lab in the world. Now, synthetic genes can only be used to make RNA vaccines, but also in 4 or 5 days, you can take the synthetic gene and splice that into several different viral vectors. And this slide on the right, you see most of the viral vectors being used today, which are alpha viruses, VSV, adenovirus, chimp adenovirus, pox virus, cytomegalovirus, measles virus. Basically, I think by this time, the gene for the spike protein of COVID has been spliced into all these viruses, and some of them I'm pretty aware they're ready to go into clinical trials pretty soon. And again, this is possible thanks to the ability to make synthetic genes and splice them into these vectors. Next slide shows another thing you can do with the synthetic genes. Synthetic genes, you can also basically generate cell lines that will produce a protein-based vaccine, like spike protein. Initially, that will take 2-3 weeks. It'll take a little bit longer, but then you can catch up with the others. One important thing when you talk about protein-based vaccines is that they do need adjuvants. Adjuvants, as you can see in the figure as an example for influenza, if you use in this case 3.75 micrograms of an influenza vaccine, you get a very modest response. But if you add an adjuvant, the response becomes huge. And the adjuvants can do several things to protein-based vaccines. One is to increase the immune response. The other thing is to increase the breadth in case of there is variation in sequence. And the other thing, you can basically increase enormously the amount of doses you can have by dose sparing, because less antigen will be required. Now, one thing which is important to understand is while what I said so far, to make a vaccine make synthetic genes is fast, developing an adjuvant is not fast. Takes 15, 20 years. So in order to make COVID vaccines, we cannot use novel adjuvants. It will take too long to establish their safety. So we'll take, so we need to use adjuvants for which we already have very good track record of safety and efficacy, so that they can be rapidly added to protein-based vaccines. Well, next slide kind of summarizes what I just said. Now we can make vaccines made three things: RNA vaccines, viral vectors, or more traditional protein-based vaccines containing adjuvants. The RNA vaccines are, as I said before, are the fastest to be developed, but there's no licensed RNA vaccines yet. So basically, this platform is not yet mature. There is not a vaccine approved as is going to change. I think this is the fastest approach. In fact, RNA-based vaccine is the first one that started clinical trials, if I remember, a week ago. So it's fast, but it's not yet proven, and there's nothing licensed, and even capacity will not be huge if the vaccine is effective. The second type of vaccines are viral vectors. I'm still on the same slide, thank you. And these are just mentioned, the ones I said before. This platform is a little bit more mature than RNA. There is already one licensed vaccine for Ebola. And so I believe it's a little bit more mature, but still it is not yet fully proven how fast this can, how effective this can be. So the third one are traditional protein-based vaccines plus adjuvants. These vaccines obviously are the ones that we know, the ones that we use already and manufacture in hundreds of millions of doses with different vaccines. So we are very comfortable that these vaccines will work. They will basically need adjuvants, and the spike proteins need to be engineered to make sure that it's in the prefusion form. But my feeling is that if we're going to need hundreds of millions of doses of vaccines to cover the global need, we will need this type of vaccines. These are the kind of horse power of the vaccines, the ones the more reliable, the one we can trust. And so I believe this will most likely the ones we're going to use in large scale. Finally, it's not part of vaccines, but I believe that while we do this, we also need to develop human monoclonal antibodies starting from PBNCs from convalescent people. I think this can be used for prevention and therapy, and they are very important. One very important point when we talk about any vaccine for COVID or human monoclonal antibodies is that for all these things, we need to do all the preclinical and clinical studies. But one scientific thing that we need to consider is what we call ADE, or antibody-dependent enhancement. It's something that has been seen that in some vaccines, for instance, for dengue, sometimes the vaccine can enhance the severity of the disease. We don't know whether that's going to happen for COVID, but some animal models have suggested that. So I think we need to make sure that these things are addressed during vaccine development. In the next slide, you will see what I've been talking so far has been developing a vaccine for laboratory work. In this slide, you see that this part which are called discovery is basically 10% of the vaccine work. Then the difficult part of making vaccines starts. Basically, you need to do a GMP material, animal models, GMP materials to do a phase 1 study. Then you need to do phase 2 and possibly phase 3 studies. And then you need a license. But in the meantime, you also need to build capacity to make vaccines, industrializations, scale up, all these kind of things. That requires time, requires huge investments, and requires companies to really invest in this. And that's really something that is needed. So basically, while the first part, making the 10% of the discovery, making a vaccine that works in the lab is pretty easy, scaling up and making a vaccine, getting to licensure so that can be available for people is much bigger investment. And in terms of time and money. So the very likely will not have a vaccine ready for at least a year or 18 months, I would say, in the most optimistic scenario. And if we really want to have a lot of vaccine doses available in 15 months, we really need to make big investments at this time. That's what I wanted to say. In the next slide is obviously, if we really want to move fast, we also need to accelerate the way we develop vaccines. And you see above here in this slide what we used to do, or we still do today. We do discovery, late development, and implementation is a very long process. For normal vaccines, it takes 15, 20 years. For Ebola, it took 5 years. Now we have a lot of new technologies that we can use to shorten the development timelines. And you see in the bottom of the slide, I think the target is to be much faster. I said 1 year instead of 15 years. It's possible with the new technologies, but we need really to embrace the new technology, be courageous, work very closely with the regulatory agencies, and move very fast. I think it's possible, but really need a global collaboration and cooperation of all the stakeholders involved in vaccine development. So that's my next. The last slide, I'm gonna just show what is 2 things have been put in the press today. One is an article in Science by Seth Berkley from Gavi. Basically says we need a huge Manhattan Project, global cooperation, big investment to make a vaccine available globally. And another quote from a book from Devin Sinclair from Harvard, the book is called Lifespan, that basically says, please remember that governments do not make vaccines, companies do. So we really need to make sure that the incentives, the governments, and the investments really take the companies that have the capacity and the knowledge to make vaccines into consideration. And with that, I will basically, that's the end of my short presentation. Hopefully I gave you an idea that the early phase, very exciting thing on making vaccines that work in animals is pretty fast. What comes later, which is the industrialization phase 1, 2, 3, and making sure that these vaccines are available in large scale, that's the big challenge. And I think we need to work all together to make sure that we speed up these things, because I believe that a vaccine for COVID is needed if we really want to, a year from now, be comfortable saying that we know how to control this pandemic. With that, thank you for your attention.
Thank you very much. Sorry, Dr. Rapulli. We're now moving on to the next speaker, which is Marco Krieger, Vice President of Fiocruz. Thank you so much. The floor is yours.
Okay. So first of all, I would like to thank for the invitation to participate in this e-conference. And how it was discussed before, we are living a unique challenge facing the COVID-19 outbreak. But at the same time, we are seeing a strong response for our research community to find new solutions to face this new disease. It's important to highlight that until now, there is no available vaccine and no drug with proven clinical efficiency against SARS-CoV-2 infection. There are several candidates which might be used in the future in the prevention or treatment, but we are still waiting for scientific evidence for this use. There are now more than 500 clinical trials registered and almost 200 currently open for recruitment of patients. The biggest challenge now is to identify evidence, even small benefits, in these studies. As important way to minimize this difficulty should be associated with a large and international study like the Solidarity trial recently launched by the WHO. This initiative aims to investigate the effectiveness of 4 different treatments for COVID-19 and will be implemented in several countries in a joint effort around the world to provide, as quick as we can, the answer on which drugs are effective and which are not effective and should not be used. With this objective, the study was planned to be executed at the same time when everyone is dedicated to caring the patients. Despite having 4 different treatment protocols, one of the premises of the study is that it is adaptable of new evidence. So the different study may be adequate with discontinuation of drugs that prove to be ineffective and also incorporation other promising drugs in this study. So I think a central and important point is how to assess the data during this process in order to avoid patients from being exposed to ineffective or highly toxic drugs. I think in the near future, we will see other organizations related to the global health community also preparing to support this kind of large-scale studies. And probably in the near future, we will see some important initiatives trying to help us to deal with different and important aspects of these big studies, like the clinical trial support, how to do the production, the regulatory issues, ethical aspect, and also how to work with the data and how to share the data. In relation to vaccine, this is really a more complex challenge because for medicine, we are trying to use now drugs already approved for use in humans. So in the case of vaccines, we will have to develop new vaccines that must only prove not only the efficiency like we are trying to do with the drugs, but before this, the safety for using humans. So as was discussed before, new vaccine development have been object of this investigation, and this was inspired by recent outbreaks like SARS, MERS, and also Ebola. So initiatives like CEPI support new technology platform like the synthetic RNA vaccine mentioned before for the rapid response for the developing a new vaccine. And in this sense, this new platform will have some information about the evaluation of safety and efficacy. This technological platforms could allow us, as was mentioned before, for a much faster evaluation. But even in this case, we will need to wait in the best case scenario for around 2 years. In addition to this challenge, the production of vaccines are usually more complicated and time-consuming than the production of medicine. So in this sense, perhaps a global initiative like the Solidarity Trial could also be important to prepare and anticipate some of the difficulties that we will have, for instance, in large-scale production, how was described before. So I think we can, for instance, discuss about a global initiative to share the production, including the capability already present in the developing country, in order to achieve the goal of billion doses production. So this was the most important points that I would like to share with you. And here in Brazil, we at Oswaldo Cruz Foundation, we are trying to work with some of our partners in this vaccines evaluation, and also we are part of the Solidarity Trial from WHO. And of course, thank you for your attention.
Thank you very much, Marco Krieger, for your presentation. And now we will move into some questions from our audience. So one here, so there are actually a few questions related to the mutation rate of this virus, and particularly how would that affect if we were able to get a vaccine, how the mutation will affect that, and how fast we could get another vaccine if needed. I don't know if Marco or Rino would like to respond.
You know, we are facing a new disease, and we have just 3 months for the evaluation of all the information about this virus. So this could be an important issue, but until now, we have some evidence that the rate of mutation is not so big as, for instance, in the case of the flu, that we need to have a new vaccine for every season. So, but of course, this will be part of the evaluation. And I think we need to have in mind that, of course, we have now the best condition to do a fast development of a new vaccine, but it's not so easy. We need to fulfill some of the scientific gap, and this mutation ratio could be one of the most important.
Thank you. Any other comment? I don't know if Dr. Rapoli would like to add anything else on this. Or... Okay, otherwise I can move to the next question. There is the question here related how the weather interacts with the virus, and whether how basically reacts the virus in cold weather, and if it could become more virulent over time.
I can also try to respond. I think it's the same situation that we faced before. We are facing a new disease, and we have some information. So part of the studies about the virus can survive related to the season, in summertime, in winter. We are just facing now. Probably is related, and but we have some publication about this, but I think we don't have until now a consensus about this information.
Thank you. Another question here, perhaps for Reno. It says, what do the speakers think about Professor Didier Raoul's treatment on COVID-19 using hydrochloroquine? Yeah, anyone?
As I told you, I think we have a lack of scientific evidence about this. So I think the solidarity, one of the arms is the study of chloroquine and hydrochloroquine. So we hope that as soon as possible, we will have enough information about this preliminary evidence. But until now, I think we have we lack the strong evidence about this.
Absolutely. Good. Maybe just one more question here. It says, can healthy people volunteer to fast track the vaccine testing? For example, bypass phase 1 and go straight to phase 2 with the people signing a risk waiver?
I think we can avoid the phase 2, but I think phase 1 is really important because it's related to safety. And in the case of vaccine, we will provide something for a people that is not sick. So I think first we need to have a strong evidence about the safety, and perhaps we can merge the phase 2 and phase 3. I think this is the new proposal, but I think phase 1 is still really important because it's about the safety to use a new product.
Thank you so much. I don't see any other question at this moment coming. Please remember the audience if anyone wants to submit any other question. Otherwise, perhaps Professor Jeffrey Sachs, if you would like to share your views.
Thank you very much. I think we're coming to the closing of this workshop, and I want to thank all of the participants. We've had a lot of people joining from around the world, and 1,000 continuing over the 4 hours, and many more than that at different phases. This is obviously because of the urgency and the high interest. We will continue to have such webinars in the coming weeks to share information and best practices. We will be posting the PowerPoints and the tape of this session for people to review and to share. I'm sure my colleagues will provide further information on that. We're in the emergency phase, and we need global solidarity at all dimensions of this, including the solidarity testing we just heard about. To develop therapeutics and vaccines, we need to do this globally. We need scientists from all over the world working openly and cooperatively. Companies need to join, but this needs to be an open scientific process. And this is extremely important that it be global and comprehensive. This is truly a worldwide battle, and while in the short term there's locking down to our most local circumstances of our own flats and our own streets and our own neighborhoods, we really are all in this together. We will not be safe if the epidemic is not controlled everywhere. We will not have an economic recovery if parts of the world are in chaos or crisis. And so even though it feels very immediate and very local, we absolutely need the global connectivity, compassion, and the cooperation to bring this horrible episode to a fast and successful resolution, success relative to the disaster and stresses and tragedies that are unfolding. So we at the United Nations Sustainable Development Solutions Network will be doing our part. Please contact us with the further questions, queries, and suggestions for how we can be providing the best services. The UN Sustainable Development Solutions Network is committed to a world of sustainable development. It's built on finding solutions to achieve the Sustainable Development Goals, including health for all, ending poverty, fighting environmental degradation, and achieving the Paris Climate Agreement. So when we are in the midst of this battle, we have to keep our focus on the most urgent short-run dynamics, but also think about the longer term and situate what we're doing within the context of leaving no one behind and of finding solutions that can work for a peaceful, cooperative, and sustainable world. Florencia, thank you for your wonderful hosting as MC today. Really grateful, and I'll turn it back to you.
Thank you so much, Professor Jeffrey Sachs, and everyone, all the remarkable panelists for making the time at this critical time to share with us your valued expertise and recommendations. And we would also like to thank all our wonderful audience. If there are any other questions, please email us. As Professor Jeffrey Sachs has said, we're going to share the link of this conference through the SESN YouTube channel, as well as the SDG Academy Library. And please check out our resources on COVID-19. Here are some examples. We have more at SESN, as well as look at our courses, and so we can learn more and work together to take this battle forward and win together. So we really hope that everyone stays safe and healthy during this time, and thank you so much again.